chair of the Advisory Committee on Immunization Practices. Today is May 19th, 2022, and I'm pleased to call today's ACIP meeting to order. I am first going to turn it over to Dr. Melinda Wharton to share today's announcements. Dr. Wharton.
Thank you, Dr. Lee. Good morning, and welcome to the May 19th virtual ACIP meeting. Copies of the slides being presented at today's meeting are available on the ACIP website or will be soon. Additionally, slides are available through a share file link for ACIP voting, liaison, and ex officio members. A few notes on meeting logistics for those who are listening in on the Zoom line. Please mute your lines at all time until you're called on for discussion. When Dr. Lee opens the meeting for discussion, please use the raise hand function in Zoom to virtually raise your hand. During the discussion period, can we go to the next slide, please? During the discussion period, Dr. Lee will take questions first from voting ACIP members and then from ex officio members and liaison representatives. We'll ask our members to please disable your video. A profile picture is fine, but just no live video. And we'll ask ACIP voting members to turn on their video during votes. Next slide, please. The Advisory Committee on Immunization Practices is at its heart a public body, and engagement with the public and transparency in our processes are vital to the committee's work. For this meeting, we'll be holding one oral public comment period today at approximately 1 p.m. Eastern Time. To create a fair and more efficient process for requesting to make an oral comment, we ask that people interested in making an oral comment to submit a request online in advance of the meeting. Priority is given to these advance requests, and if more people request to speak than can be accommodated, we conduct a blind lottery to determine who the speakers will be. Speakers selected in the lottery for this meeting have been notified in advance of the meeting. Members of the public can also submit written public comments via regulations.gov using docket number ID CDC 2022-0065. Information on the written public comment process, including information on how to make a comment, can be found on the ACIP meeting website. Next slide, please. As noted in the ACIP Policies and Procedures Manual, members of the ACIP agree to forgo participation in certain activities related to vaccines during their tenure on the committee. For certain other interests that potentially could enhance a member's expertise while serving on the committee, ACIP has issued limited conflict of interest waivers. Members who conduct vaccine clinical trials or serve on data safety monitoring boards may present to the committee on matters related to those vaccines, but these members are prohibited from participating in committee votes on issues related to those vaccines. Regarding other vaccines of the concerned company, a member may participate in discussions with the provision that he or she abstain from all votes related to the vaccines of that company. At the beginning of each meeting, ACIP members state any conflicts of interest. Next. We are currently soliciting applications and nominations for candidates to fill upcoming vacancies on the committee. Detailed instructions for submission of names of potential candidates to serve as ACIP members is now available on the ACIP website. Applications for ACI membership are due no later than July 1st, 2022 for the 4-year term beginning in July 2023. Next. And with that, I will turn the virtual podium back over to Dr. Lee. Thank you.
Thank you, Dr. Wharton, and I do want to emphasize that please do apply for ACIP membership for those who are listening. For the ACIP members today, I will take roll call. I'll ask that you state your name, your affiliation, and whether you have any conflicts of interest. And today we are going to start with Dr. Bell.
Good morning. I am Beth Bell. I'm a clinical professor in the Department of Global Health at the University of Washington, and I have no conflicts.
Thank you, Dr. Bell. Next, Dr. Cotton.
Good morning, Camille Nelson Cotton. I'm the Clinical Director of Transplant and Immunocompromised Host Infectious Diseases at Massachusetts General Hospital and Associate Professor at Harvard Medical School. I have no conflicts.
Thank you. Dr. Chen.
Good morning. Wilbur Chen, Professor of Medicine at the University of Maryland School of Medicine's Center for Vaccine Development and Global Health. I have no conflicts.
Thank you, Dr. Chen. Dr. Daly?
Good morning. Matt Daly. I'm a senior investigator at Kaiser Permanente, Colorado. I'm also an associate professor of pediatrics at the University of Colorado School of Medicine. I have no conflicts.
Thank you. Dr. Paling?
Good morning. This is Kathy Palin. I am professor of pediatrics and epidemiology and prevention at Wake Forest School of Medicine, Atrium Health, Wake Forest Baptist. I have no conflicts. Thank you.
Thank you, Dr. Paling. Dr. Talbot?
Good morning. I'm Kip Talbot. I'm an adult infectious disease doctor at Vanderbilt University Medical Center.
Do you have any conflicts, Dr. Talbot?
Oh, sorry. No conflict.
Thank you. Dr. Lair?
Good morning. This is Jamie Lair. I'm the owner of Chuga Family Medicine, a private medical practice in Ithaca, New York, and I have no conflicts.
Thank you, Dr. Lair. Ms. Bata?
Good morning. This is Lynn Bata. I'm the immunization clinical consultant at the Minnesota Department of Health, and I have no conflicts.
Thank you. Dr. Sanchez?
Pablo Sanchez. I'm a professor of pediatrics at the Ohio State University College of Medicine. I'm a neonatologist in pediatric infectious diseases at OSU and Nationwide Children's Hospital. I have no conflict. Thank you.
Thank you. Ms. McNally?
Good morning. Veronica McNally, president of the Franny Strong Foundation based in Michigan, and I have no conflicts.
Thank you. Sorry, I'm trying to scan. So this is Grace Lee. I'm a professor of pediatrics at Stanford University School of Medicine, an associate chief medical officer for Stanford Children's Health, and I have no conflicts. I did see Dr. Long. Dr. Long, are you on?
Yes, this is Sarah Long. Good morning. I'm a pediatric infectious disease doctor and professor of pediatrics at Drexel University College of Medicine in Philadelphia, and I have no conflict of interest to disclose.
Thank you. Let me just check on a few members. We have folks who are delivering babies and seeing patients in clinic and in various settings. So I just want to confirm Dr. Alt, Dr. Brooks, Dr. Sineas. Okay, we will come back to those three. I know they are planning to join, but they just might need a few minutes to log in. We do also have quorum at the moment, so we can proceed. For our ex officio and liaison members, I will announce the organization name, and please indicate if you are present and your first and your last name. Centers for Disease Control and Prevention.
Good morning, Sam Posner.
Thank you. Dr. Posner. Centers for Medicare and Medicaid Services.
Good morning, Mary Beth Hance.
Thank you. Food and Drug Administration.
Good morning, Doran Fink on behalf of the U.S. Food and Drug Administration, Office of Vaccines.
Thank you. Health Resources and Services Administration.
Good morning, Mary Rubin from the Division of Injury Compensation Programs, HRSA.
Thank you. Indian Health Service.
Good morning, this is Dr. Matthew Clark with Indian Health Service.
Thank you. National Institutes of Health.
Good morning, John Bargo from the National Institute of Allergy and Infectious Disease representing NIH.
Morning and thank you. Office of Infectious Disease and HIV/AIDS Policy.
Good morning, David Kim with OIDT in the Office of the Assistant Secretary for Health.
Thank you, Dr. Kim. Next, we'll move on to our liaison representatives, American Academy of Family Physicians.
Good morning, Dr. Pamela Rockwell, Professor of Family Medicine at the University of Michigan Medical School, representing the American Academy of Family Physicians.
Thank you. American Academy of Pediatrics. Dr. Maldonado. Okay, we'll come back. American Academy of Physician Assistants. American College Health Association.
Good morning, Sharon McMullen, representing ACHA.
Thank you. American College of Nurse Midwives. American College of Obstetricians and Gynecologists.
Good morning. This is Dr. Linda Eckert. I'm a professor of OBGYN and Global Health at University of Washington, representing ACOG. Thank you.
Thank you, Dr. Eckert. American College of Physicians. American Geriatric Society.
Ken Schmader for AGS.
Thank you. I'll have to go fast. I'm going to run down the list, and we'll come back and catch people who might have joined in the interim. America's Health Insurance Plans. American Immunization Registry Association.
Good morning. Elizabeth Perillo with the American Immunization Registry Association.
Thank you. American Medical Association. American Nurses Association.
Sandra Freihofer, practicing general internist in Atlanta, adjunct associate professor of medicine at Emory University School of Medicine, representing the American Medical Association.
Thank you, Dr. Freihofer. Do we have someone on from the ANA, American Nurses Association? We'll move on to the American Osteopathic Association. Association of Immunization Managers.
Molly Howell, representing AIM.
Association for Prevention, Teaching, and Research.
Hi, Chrissy Moline-Jessel, Assistant Professor, Department of Family Medicine at the University of Pittsburgh, representing as an alternative liaison for APTR.
Thank you. Association of State and Territorial Health Officials.
Good morning. This is Nirav Shah. I'm the Director of the State of Maine, CDC, and the President of ASTO.
Thank you. Biotechnology Innovation Organization.
Good morning. Phyllis Arthur on behalf of BIO.
Thank you. Council of State and Territorial Epidemiologists.
Christine Hahn, present.
Thank you. Canadian National Advisory Committee on Immunization.
Good morning. Kelly Deeks from NACI.
Thank you. Infectious Diseases Society of America.
Good morning. This is Jeff Duchin representing the IDSA.
Thank you. International Society for Travel Medicine. We'll move on to the National Association of County and City Health Officials.
Good morning. This is Matt Don representing NACHO.
Thank you. National Association of Pediatric Nurse Practitioners.
Good morning. It's Patsy Stinchfield representing NAPNET.
Morning. National Foundation for Infectious Diseases.
Good morning. This is Bill Schaffner, Medical Director of the NFID.
Thank you. National Medical Association.
Good morning. This is Dial Hewlett, representing the National Medical Association.
Thank you. Pediatric Infectious Disease Society.
Good morning. Sean O'Leary, representing PIDS.
Thank you. Pharmaceutical Research and Manufacturers of America.
Good morning. Corey Robertson, present.
Thank you. Society for Adolescent Health and Medicine. Okay, going back up, I'm going to ask American Academy of Pediatrics Red Book. My apologies, Dr. Kimberlin.
David Kimberlin, AAP Red Book.
Thank you.
And my connection dropped off. Bonnie Maldonado, Chair, Committee on Infectious Diseases, American Academy.
Thank you, Dr. Maldonado. I see American College of Nurse Midwives.
Carol Hayes, present.
Thank you. If anyone else wants to raise their hand if they were not able to announce themselves in my rapid read of our liaison representatives, please go ahead and do so. Oh, thank you. Dr. Sineas.
Hi, Sybil Sineas. I'm an internist and pediatrician, associate professor of medicine and pediatrics at the Warren Alpert Medical School of Brown University, and I have no conflicts.
Thank you, Dr. Sineas. She is coming in as an ACIP member. Are there any additional individuals who have joined after roll call? Please raise your hand. Okay. Well, thank you, everyone, and I anticipate we will have additional members joining later in the day. At this point, I'd actually like to invite Dr. Rochelle Walensky, the Director of the CDC, to provide a few opening remarks to the committee today. Dr. Walensky?
Thank you so much, Dr. Lee, and good morning, everyone. It's great to be back with you today, and I remain so grateful to all of you and the heavy lift you have done as we continue to address COVID-19. I, of course, can't be with you today and not acknowledge the tragic and heartbreaking milestone that we marked this week. More than 1 million reported deaths from COVID-19 in the United States. We know that every family, every community, and workplace across the nation has experienced the enormous cost of this pandemic, and some have experienced a disproportionate share of the deaths and the suffering. I know all of you listening have been profoundly impacted and have experienced the toll of this pandemic has taken on the health of your communities, your patients, and your family. We all hope to never see the death tolls rise this high, reaching a number that was unfathomable when we first learned of this virus. The sadness I feel for lives lost, the families devastated, and the communities changed is deep. At the same time, we're seeing yet another surge in cases and increased hospitalizations, especially among older adults and those who are immunocompromised. We have the tools we need to protect these people from severe disease and prevent any more tragic deaths. With your help, we've been able to increase access to vaccines for people across the country and provide guidance for those at increased risk of disease. Still, there are too many who do not have the protection necessary as we face yet another increase in cases and hospitalizations. I'm very much looking forward to ACIP reviewing the data around a booster dose for 5 to 11-year-olds and appreciate your input on the important decision and how we can best protect them. For older Americans, we've worked together to follow the epidemiology closely. Over the past few weeks, we've seen a steep and substantial increase in hospitalizations for older Americans. At the same time, only 38% of those 50 to 64 and 43% of those 65 and older have received a vaccine dose in the past 6 months. This leaves about 60% of older Americans without the protection they may need to prevent severe disease, hospitalization, and death. We know immunity wanes over time, and we need to do all we can now to protect those most vulnerable. It's important for us to anticipate where this pandemic is moving and deploy the tools we have where they will have the greatest impact. As a clinician, as a member of my own community, I've strongly recommended that my loved ones and those in my community who have older receive a vaccine booster dose. I have received one myself. As the director of CDC, I know that it's important to share that the same strong recommendation with older Americans, encouraging those who have not received a booster dose in the last 5 months to get another dose. I listened to and appreciate your nuanced discussion on this very challenging issue last month at a time when infections were much lower than they are now. And I will continue to look to you for your future discussions and guidance as we think through the need for additional booster doses in all age groups. So I started with gratitude, and I certainly want to end on the same note. Thank you for your commitment to saving lives. Thank you for your dedication to equity and better health for all. Thank you for doing this while living and through this experience and the impact of this pandemic each and every day. Thank you.
Thank you so much, Dr. Walensky. I will turn it over next to Dr. Doran Fink from FDA CBER, Office of Vaccines, for an update. Dr. Fink.
Hi, thank you, Dr. Lee. We are meeting today, of course, because 2 days ago, FDA extended the emergency use authorization of the Pfizer BioNTech COVID-19 vaccine to include use as a booster dose in children 5 through 11 years of age. This regulatory action followed a review of immunogenicity and safety data from an ongoing trial evaluating the booster dose in children in this age group. FDA also evaluated accumulated safety data to date from use of the vaccine in this age group, including data on the incidence of vaccine-associated myocarditis, and also reviewed vaccine effectiveness data that clearly show the benefit of a booster dose in preventing COVID-19, including its serious outcomes in individuals of all ages with the added benefit conferred by a booster dose over the primary series. We do acknowledge that many children in this age group have recently experienced an infection of SARS-CoV-2 with the Omicron variant during recent waves, and that considerations around benefits from vaccination versus natural immunity will be different for different individuals. However, considering the balance of benefits and risks and the totality of available evidence, we did think that it was important and the right thing to do to make this vaccine available as a booster dose for use in children 5 through 11 years of age for all individuals in this age group who would like to increase their protection through vaccination. Before I conclude, I also want to acknowledge the continued intense interest in the availability of COVID vaccines for the youngest pediatric age groups, children under 5 years of age. As has been reported, the emergency use application from Moderna was completed just recently with submission of data sets, and we are working hard to review these data and to bring the request to our Vaccines and Related Biological Products Advisory Committee as rapidly as we can. We are also awaiting a request and data to support that request for the Pfizer vaccine. And once received, we will move again as rapidly as we can to bring those data to our advisory committee for discussion and recommendation. Thank you.
Thank you so much, Dr. Fink. And I want to turn it over now to Dr. Amanda Cohn from CDC for a few words.
Good morning, everyone. Thank you for having me back, Dr. Lee. And I just wanted to share a couple of thoughts that we have been having related to our process and approach for all of you to think about today and the many, many future meetings we will be having. As most of you know, CDC, NCRD, and the ACIP Secretariat is deeply committed to using the evidence to recommendations framework for our decision-making process. I am really proud of how effective the ETR framework has been to allow for transparency and deliberation, and really appreciate how important it is to all of the ACIP members and liaisons as part of our decision-making process. We've also kept this framework nimble, as demonstrated by our adding an equity component to the framework early on during the pandemic. But we never anticipated that we would be using this framework on nearly a monthly basis, and for so many distinct questions related for a vaccination program. As the CDC team was previewing the slides for the discussion today, it occurred to us that as the policy questions become more specific, the data presented in the ETR framework is also very specific to that question, and sometimes the context is not as well represented. But this takes me back to the reason why we have 15 voting members, and part of your job is to review the data specific to this policy question, but in your decision-making process to incorporate the broader context of the COVID immunization program and where we are today with the pandemic and with vaccination as a whole. At the end of last year, I remember promising that we would be moving to a more holistic recommendation approach this year. I wanted to acknowledge that it is clear we are not at that moment yet, as I hope we still can commit to doing that by the end of this year. But it's certainly, there are too many individual decisions that will have to be made over the coming months. But as I know you always do, I just want you all to think about following the science for this specific recommendation today, but also thinking ahead towards when we do have holistic recommendations for our COVID vaccination program. Thanks.
Thank you so much, Dr. Cohn. I do want to call on Dr. Oliver Brooks, our ACIP member. Could you please state your name, affiliation, and whether you have any conflicts of interest, Dr. Brooks?
Yes, good morning. Oliver Brooks, Chief Medical Officer, Watts Healthcare Corporation, and I have no conflicts.
Thank you, Dr. Brooks. Thank you so much. I want to thank Dr. Walensky, Dr. Fink, and Dr. Cohn for continuing to, serve in these leadership roles for all of us. I had not planned to say anything, but I did want to respond. I feel like it is sobering that we have experienced over 1 million deaths in the U.S. as a consequence of COVID infection. I had never thought in December 2020, when we as ACIP first approved vaccines for use, that we would be where we are today. As Dr. Cohn mentioned, I had not anticipated we would be meeting on nearly a monthly cadence, looking at every single decision and trying to review every single piece of data coming in. I have found this experience to be absolutely humbling. We all feel we are here to protect the health of every individual, and we have good tools in hand, but I do think we're going to continue to need better tools, and we are going to continue to need to adapt our approach to protect the population because this virus continues to evolve and change. I was wishing this could be one simple answer back in December 2020, but COVID clearly won't let us do that. So I really appreciate our committee being willing to come together and to continue to address these really difficult questions that are in front of us, recognizing that we want to support implementation across the population, recognizing we all want to protect the health of individuals, and recognizing this is not an easy feat, no matter which direction we head. So appreciate everyone's patience and your willingness to reflect on your perspectives and share that with the committee as well as the public. It is really important. This process is really important as part of this decision making that needs to happen, and I do believe the transparency and public nature of this meeting make a huge difference in our ability to be confident in the vaccination program. So I want to thank everyone today for being here. And with that, we will now move on to our first session of the day. Dr. Matt Daly, who is chair of the COVID-19 Vaccines Work Group, will provide an introduction and overview of our sessions for today. Dr. Daly?
Thank you very much, and good morning, everyone. I'll wait a sec for slides to be up. Okay, thank you so much. So I'm speaking today on behalf of the ACIP COVID-19 Vaccines Work Group. Next slide. There have been more than 82 million reported cases of COVID-19 in the U.S. since the beginning of the pandemic. Next slide. Several hundred individuals are dying each and every day in this country from COVID-19. And as Dr. Walensky discussed in her opening remarks, we've reached the tragic milestone of 1 million deaths from COVID-19 since the start of the pandemic. Next slide, please.
Hey, Dr. Daly, give us just a second. We're having some, the slides aren't projected. They're projecting for you, but not for the public. So give us just a second to fix this. Thanks.
Okay, yeah, I can see it on my screen, but just tell me when you're ready for me to go. Thank you.
Okay, will do. Thanks.
We'll take a couple minutes, and we'll be back in about 3 minutes. Okay, Dr. Daly, I believe we've resolved our technical issue and can resume.
Okay, thank you so much. Thanks, everyone. Picking up right where we left off, this slide shows rates of COVID-19 associated deaths by vaccination status. And to orient you to the content, the graph on the left shows rates of death for those 5 and over, comparing rates among the unvaccinated to rates among those who've been vaccinated with at least the primary series. Unvaccinated people 5 years of age and over had 10 times the risk of dying from COVID-19 in February of 2020 compared to people vaccinated with at least the primary series. The graph on the right shows rates of death for those 12 and older, and these compare rates of death among the unvaccinated, which is the black line, to rates among those vaccinated with the primary series only, which is the broken blue line, compared to those vaccinated with a primary series and a booster dose, which is the solid blue line at the bottom. And unvaccinated people ages 12 and over had 20 times the risk of dying from COVID-19 in February of 2020, compared to people vaccinated with a primary series and a booster dose. And these graphs are here not to shame or blame those who remain unvaccinated. We really show these graphs simply to demonstrate why we believe that vaccination is the most effective thing you can do to protect yourself against dying from COVID. And then these graphs also are a potent reminder that we need to redouble our efforts to communicate this even more effectively to the public, and that includes vaccination with the primary series and vaccination with the booster. Next slide, please. And so this slide is presented in a very similar context. These are new analyses which predict that vaccines could have prevented at least 318,000 COVID-19 deaths between January of 2021 and April of 2022, had the pace of vaccination been maintained until 100% coverage was achieved in the adult population. Next slide, please. So some have argued that COVID vaccines are not necessary for children because COVID doesn't cause serious disease in this age group. And this is clearly not the case. And what we wanted to do here was contrast hospitalizations from COVID to hospitalizations from other vaccine-preventable pediatric diseases. And as shown, COVID-19 has comparable or higher hospitalization rates than for other pediatric vaccine-preventable diseases such as hepatitis A, varicella, and influenza. Next slide, please. And this slide shows deaths per year in the United States prior to recommended vaccines. And deaths from COVID-19 in the U.S. in 5 to 11-year-olds are greater than for a number of other pediatric vaccine-preventable diseases. And it's important to highlight that vaccine coverage for these other conditions, these other diseases, is relatively high, indicating that most parents accept vaccination for hepatitis A, meningococcal, varicella, rubella, and rotavirus, even though deaths from these diseases are relatively rare. And to state this another way, all of these diseases, including COVID-19, represent vaccine-preventable deaths. And it's also important to note that when discussing disease burden from COVID-19 in children, we also need to consider the burden from post-COVID syndromes in this age group. Next slide, please. So the FDA update that Dr. Fink referred to is here. 2 days ago, the FDA authorized a COVID-19 vaccine booster dose for children 5 through 11 years of age. And to read this verbatim, FDA amended the emergency use authorization for Pfizer-BioNTech COVID-19 vaccine, authorizing the use of a single booster dose for administration in individuals 5 through 11 years of age at least 5 months after completion of a primary series with Pfizer-BioNTech COVID-19 vaccine. Next slide, please. So this slide illustrates the current recommendations for COVID-19 vaccines in children 5 through 11 years of age. At the top are recommendations currently for individuals who are not moderately to severely immunocompromised, which is 2 doses of a primary series separated by 3 weeks. And down below are recommendations for persons who are moderately or severely immunocompromised in this age group with a 3-dose primary series. Next slide, please. So this slide highlights the COVID-19 vaccine workgroup activities in April and May of 2022. We reviewed data on vaccine response by type of immunocompromise in adults. We also reviewed data relevant to seroprevalence of infection-induced SARS-CoV-2 antibodies. We also reviewed COVID-19 epidemiology in this age group. In addition, we heard the safety and immunogenicity data for Pfizer-BioNTech COVID-19 vaccine booster dose in children 5 through 11 years of age. We also evaluated vaccine effectiveness data for COVID-19 vaccines in children in this age group. We also reviewed safety data for COVID-19 vaccines for children in this age group. And then finally, we had extensive policy discussions around the use of booster doses in this age group. Next slide, please. So here's the agenda for today, Thursday, May 19th of 2022. First, we're going to hear from Dr. Link Gellas from the CDC, who's going to review updates on vaccine effectiveness of COVID-19 vaccines in children ages 5 through 11 years of age. Following that, we'll hear from Dr. Shimabukuro from the CDC, who will review updates on safety of COVID-19 vaccines in this age group. Following that, we'll hear from Dr. Talbot, who's an ACIP member and the VAST chair, who will provide the Vaccine Safety Technical Subgroups assessment of safety COVID-19 vaccines in this age group. We'll then have a break. The break will be followed by public comment period. After that, we'll hear from Dr. Shabarwal from Pfizer, who will review the safety and immunogenicity of BNT162b2 booster dose, which is a 10 microgram dose in children ages 5 through 11 years of age. Then following that, we'll hear from Dr. Oliver from the CDC, who will review updates to the ETR framework for COVID-19 vaccine booster doses in children ages 5 through 11 years of age. We'll then have a discussion and a vote on this topic. Next slide, please. So I want to very sincerely thank the ACIP COVID vaccine workgroup members, including ACIP members, ex officio and government members, liaisons, consultants, and the excellent leadership of Dr. Sarah Oliver, and the CDC participants who made all this happen. Next slide, please. I turn it back to you, Dr. Lee.
Thank you so much, Dr. Daly, for walking us through the events for today. We'll turn it over to Dr. Link Gellas to review updates on vaccine effectiveness in children 5 to 11 years of age. And we'll just wait for her slides to come up.
Good morning. Today I'll be sharing brief updates on vaccine effectiveness during Omicron for children and adolescents. Some of these slides have been shared previously with ACIP or come from previously published work and could not be updated due to the relatively few cases once the Omicron BA.1 wave subsided.
Dr. Link Gellas, we can see your slides now.
Thank you. Next slide, please. I'll start first with CDC's PROTECT platform. This is a prospective cohort study in children aged 4 months to 17 years that includes weekly swabbing regardless of symptom status, so should not be impacted by changes in testing practices due to the availability of home tests. The study uses a Cox proportional hazards model with adjustment for propensity to be vaccinated, site and SARS-CoV-2 circulation, and community mask use. Results were separated
Dr. Link Gellas, apologies for interrupting, but you keep cutting in and out. If you could get closer to the mic, I know our members would love to hear you.
Let me switch mics, hang on. Okay, I hope this is better.
That is much better, thank you.
Great. Next slide, please. Next slide, please. Great. These results are updated from the Folks et al. MMWR published in March and extend those findings through April 23rd. Here we have VE against infection for 5 to 11-year-olds on the top and 12 to 17-year-olds on the bottom, further separated by time since last dose. Note that for the 5 to 11-year-old age group, there was not enough power in the 60-plus days after the second dose, and so the confidence interval was too wide to make meaningful conclusions, so we did not include that estimate here. For the 14 to 59 days after the second dose, note that although the point estimates are different for the two age groups, the confidence intervals for the adolescent group overlap entirely with the confidence intervals for the younger children. In the adolescent group, a booster dose provides a significant increase in VE, bringing VE up to 83%, a median of 95 days or more than 3 months after the booster dose. Next slide. Moving on now to the Increasing Community Access to Testing, or ICAT platform, which is a national community-based drive-through testing data from pharmacies. This platform relies on self-reported vaccine history and uses a test-negative design where cases are persons with at least... Did we lose the slides? Okay. Cases are persons with at least one COVID-like symptom and positive NAT test, and controls are symptomatic with a negative NAT test. Models are adjusted for the variables shown here and not adjusted for prior infection. We present data on adults first to show the differences between Delta and Omicron. Adults were tested from December 10th through January 1st, with Omicron determined by S-gene target failure. Tests in kids were included between December 26th and February 21st, when almost all circulating disease in the country was Omicron. These results have been previously shared with ACIP, but we've included them here for completeness. Next slide. This is previously published adult data for Delta in orange and Omicron in blue by time since the second dose, shown on the x-axis, with VE on the y-axis and the dotted line showing the 95% confidence intervals. You can see the lower starting VE for Omicron and much quicker waning compared to Delta, including 0 in the confidence interval by 3 months after the second dose. Next slide. Now we show the same adult data for Delta and Omicron, and overlay data from adolescents 12 to 15 years of age in black and children 5 to 11 years of age in pink. Note the much shorter follow-up time for the 5 to 11-year-olds due to vaccine being recommended for them in November. Generally, we see almost identical patterns across the age groups, with 2 doses of mRNA vaccines providing roughly 60% protection initially and quickly waning to around 20% and lower by a few months after the second dose. In the blue box to the right, note that a booster dose provided substantial additional protection to adolescents, with 71% VE up to 66.5 weeks after the third dose, higher than even the initial VE immediately following a second dose. Next slide. Moving on now from VE against infection to VE for emergency department and urgent care visits and hospitalization. The VISION network is a multi-state network based on electronic healthcare records. Like ICAT, it uses a test-negative design with cases having CLI and a positive PCR, and controls having CLI with a negative PCR. VE is adjusted for propensity to be vaccinated weights, calendar time, region, local virus circulation, and age and vaccination is determined via health records and state and city registries. Next slide. This is an update to data included in the Klein et al. MMWR in March, showing VE against emergency department and urgent care for children 5 to 11 on the top and adolescents 12 to 15 on the bottom. As with the PROTECT platform, there was not enough power to include VE for greater than 60 days after the second dose for children. For the 14 to 59 days after the second dose, we see almost identical VE point estimates in the two groups, with wide confidence intervals for adolescents and some indication of waning after 60 days. On the bottom of the slide, I've noted the case definition for ED-UC visit, which highlights here the potential for inclusion of children visiting urgent cares and EDs with COVID instead of for COVID, likely a bigger concern for kids than for adults, as the case definition includes GI symptoms, which may have many frequent non-COVID causes in kids and could potentially drive VE estimates for ED and UC visits closer to those of infection in children. As with infection, a booster dose provided a significant increase in VE for adolescents up to a median of 45 days after the booster. Next slide. Here again from Vision, we have VE of 2 doses against hospitalization for children 5 to 11 and adolescents 12 to 18 years of age during Delta and Omicron. This slide has been previously shared with ACIP and published via MMWR. Updated data were not available due to the relatively few children hospitalized once the Omicron wave subsided. For the 5 to 11 group, you can see that there were only 2 hospitalizations during the study period, which included 2 months after children in that age group could be fully vaccinated. While the point estimates for 5 to 11-year-olds, 74%, is lower than the point estimate for 12 to 15-year-olds, 92%, that is likely because the younger age group included 67% Omicron cases, for which VE is lower compared to earlier variants, while the older group included only 15% Omicron cases. Next slide. Finally, I'll show results from the Overcoming COVID platform. Overcoming COVID is a test-negative VE platform specifically aimed at children and adolescents hospitalized at 31 pediatric medical centers in 23 U.S. states. As with other platforms, cases have CLI and a positive test, while controls have CLI and a negative test. Vaccination status is determined using a combination of documentation in the medical record and self-report and modeled via logistic regression. Next slide. This is an update to a recent publication in New England Journal of Medicine. We see here VE for 5 to 11-year-olds of 68% to a median of 37 days after the second dose, and VE for 12 to 18-year-olds of 51%. In the older kids, we can see VE split by time since vaccination, with some indication of waning at 23 to 45 weeks after the second dose. Unfortunately, uptake of booster doses in adolescents was not high enough to assess additional protection against hospitalization afforded by a booster dose. Next slide. Here we have updated data on VE against MIS-C for both age groups, with VE of 78% for kids and 90% for adolescents. We do not see a signal here for waning in the adolescent group in the more than 120 days after vaccination. And we did not have power to assess additional protection due to a booster, similar to hospitalization. Next slide. In summary, for infection, 2-dose VE quickly declined for children and adolescents during Omicron and followed a nearly identical pattern of that to adults. A booster dose in adolescents significantly improved VE in the 6 weeks to 3 months after the third dose, depending on the platform studied. A similar pattern was noted for emergency department and urgent care visits, with similar VE after 2 doses in both age groups, and declining VE after the second dose in adolescents, and substantial additional protection from a third dose. Finally, for severe disease, 2 doses provided protection for both children and adolescents, with some waning evident for hospitalization in adolescents. There was not enough power to assess waning in children or the impact of boosters against hospitalization or MIS-C in adolescents. Next slide. I'd like to quickly acknowledge just some of the many individuals who provided data for this study, and I'd be happy to take any questions. Thank you.
Thank you so much, Dr. Link-Ellis. This presentation is now open for questions and discussion.
Yes, can you hear me?
We can. Please go ahead.
Okay, wonderful. So, Dr. Link-Ellis, first of all, I want to say thank you. This is a very important information that you have shared, and I wanted to reiterate that there was a common finding in all about the protection for children 5 to 11 as well as 12 to 17. I think, and I would love for you to comment, that these are very large databases to get the data. And so it would reflect a lot of diversity in socioeconomic status as well as race and ethnicity. And if you could provide some insight on that, that would be most helpful. Thank you.
Sure, happy to. So it depends a little bit on the platform under study. For example, the ICAP platform is national pharmacy testing data, so it would include individuals tested through the increasing community access to testing program, which was specifically aimed to increase testing in areas of low socioeconomic status. And so that platform in particular should have very good representation in lower SVI areas. Other platforms, such as the Vision Network, include large medical centers or even entire states, like the state of Indiana, and so should have pretty good representation across urban, rural, low and high SVI areas and different racial and ethnic makeups. Thank you.
Thank you. Dr. Talbot?
Yeah, and I have a question. I'm not sure you can answer it if it's coming later, so feel free to tell me, wait my turn. Can you tell me how many kids 5 to 11 and 12 to 17 have actually been vaccinated? What percentage? Thank you.
Hey, Dr. Talbot, this is Dr. Oliver. We'll go over in detail that information in the ETR presentation, but it is around 28% that have received 35% that have received at least one dose and 28% that are fully vaccinated. Thanks.
Thank you.
Are there additional questions? I do not see any additional hands raised. I just want to emphasize real quickly, and perhaps in future presentations you can affirm this, but to Dr. Paling's question about sort of the diversity and inclusion of participants or in the surveillance systems that are being studied, it might be helpful to take a look also at whether or not there's any variation or effect modification in vaccine effectiveness. I would not anticipate there would be, but to have that affirmed might be actually very helpful. Any other questions from our liaison members? Okay, I don't see any hands raised. Thank you very much, Dr. Link-Ellis. At this point, we will transition to Dr. Shimabukuro from CDC for updates on the safety of COVID-19 vaccines in children 5 to 11 years of age. I'm just going to flag for our colleagues in the CDC room that we will, after Dr. Shimabukuro, we will move to Dr. Kip Talbot's presentation to provide the VAST assessment, and then we will open for discussion. So we'll first wait for Dr. Shimabukuro's slides to come up, and we'll go from there.
Dr. Lee, while we're waiting, I just want to do a quick sound check. You can hear me?
We can hear you, Dr. Shimabukuro. And your voice dropped another octave. I hope you're feeling better.
Thanks.
Dr. Long, did you have a question about the last presentation?
Yeah, well, I could hold it now that I see the slides are up.
Okay. If that's okay, that would be terrific. I'd appreciate it. Let's go ahead with Dr. Shimabukuro's presentation.
Thanks. Could we go to the next slide, please? Next slide, please. I'm still on the title slide. Is that what you're seeing as well, Dr. Lee? Okay.
It is, yes. I'm hoping that we can move to the next slide so you can get started. Perfect, thank you.
Thanks. So today I'll be covering post-authorization safety monitoring for primary series Pfizer BioNTech or Comirnaty COVID-19 vaccination in children ages 5 to 11 years. I'll be covering data from the Vaccine Adverse Event Reporting System, or VAERS, VSafe, and the Vaccine Safety Data Link. Next slide. So VAERS is the National Spontaneous Reporting or Passive Surveillance System that's co-managed by CDC and FDA. Next slide. VAERS accepts reports from everyone, including healthcare professionals, patients, parents, caregivers, and manufacturers, regardless of the plausibility of the vaccine causing the event or the clinical seriousness of the event. Key strengths of VAERS is that it can rapidly detect potential safety problems and can detect rare adverse events. Key limitation is generally we cannot determine cause and effect from VAERS data alone. Next slide. Next slide. So this is a summary table of U.S. reports to VAERS.
Dr. Shimabukuro,
Yes.
I'm so sorry. Could you give us a moment to resolve some technical issues? Thank you.
Certainly.
Okay, we're going to take 10 minutes and try to get some, we're going to take 15 minutes and try to get some AV issues resolved. Thank you. Sorry, we'll be back at 12:15.
That's right.
Okay, I believe we're ready to resume. So Dr. Shimabukuro.
Thanks, Dr. Wharton. So just to reorient you, maybe if you hadn't caught the first part of it, this is the vaccine safety presentation covering post-authorization safety monitoring of Pfizer vaccination primary series in children 5 to 11, and I'm about to move into data on the vaccine adverse event reporting system, which is CDC's and FDA's spontaneous reporting or passive surveillance system. Next slide. So this is a summary table of U.S. reports to bears among children 5 to 11 after Pfizer vaccination. In this age group, there's been, during the analytic period we're looking at, there's been approximately 18.1 million doses administered. There's been just over 9,000 reports. The median age in this age group is 8 years. The reports are equally split between males and females. Where you see they don't add up to 100 is because that's a small number. There's a small number of reports that have sex missing. And 97% of the reports in this age group are non-serious. Next slide. So this is the table showing reports by race and ethnicity. Next slide. These are the most frequent measure of preferred terms, which are the codes we use to assign signs and symptoms. In non-serious reports to bears, on the left-hand side, you have all non-serious reports, which includes these non-clinical outcomes. So non-clinical outcomes like no adverse event, product preparation issue, incorrect dose administered, storage error, underdose, likely represent Medicaid or vaccination errors. When we exclude those non-clinical outcomes, you get the table on the right-hand side there, and the most commonly reported events are systemic and local reactions. Next slide. It's the same type of table except for serious reports. You have all reports there on the left-hand side, and then you have the top adverse events when we exclude the non-clinical outcomes. Next slide. So now I'm going to move into the data on myocarditis following Pfizer vaccination. But before I do that, I'm going to spend some time going over the background of the epidemiology of myocarditis, the epidemiology of myocarditis associated with mRNA COVID-19 vaccination, and then refresh you on some of the data that's been previously presented. So classic myocarditis in children is usually the result of an infectious cause, typically viral or presumed to be viral, although an infection with a pathogen is frequently not identified. It can be due to direct microbial infection of myocardial cells and or ongoing inflammatory response with or without clearance of the pathogen. It can also be toxin-mediated or in a setting of systemic infection or infection of non-cardiac tissue. Rare causes include autoimmune hypersensitivity and giant cell. Incidence is higher in males than in females, starting after ages 5 years. Previously unrecognized myocarditis was identified as a cause of death in 8% of cases of sudden unexplained death in 1 to 17-year-olds and 9% of sudden death in athletes. Just to reiterate, it is common to not identify a pathogen or possible infectious etiology for myocarditis. Based on case series in the literature where autopsy tissues were examined and tissue-based infectious disease testing was performed, specific infectious cause was identified only in 13 to 36% of cases across age groups. And for a case series where endomyocardial biopsy tissues were tested, viral nucleic acids were detected in heart tissues in approximately 38%, so that's adults and children combined. Next slide. These are figures from a slide that was previously presented at ACIP showing epidemiology of myocarditis. On the left-hand side, we have a figure with children. So you can see that once you get out of the infancy period, where other factors such as genetic may be playing a role, myocarditis incidence is quite low, and then starts to increase in adolescence. And on the right-hand side, we have data from adults, and you can see really peaking in adolescence, and then gradually decreasing over time, at least for males. For females, it's a bit of a different picture. Next slide. So this is a side-by-side comparison of characteristics of myocarditis associated with COVID-19 mRNA vaccination and viral myocarditis. I'll just walk you through this table. First, for inciting exposure, of course, for vaccine-associated myocarditis, it's mRNA COVID-19 vaccination with the risk for dose 2 greater than for dose 1. For viral myocarditis, viral illness, with 30 to 60% of these illnesses having an asymptomatic course. For demographics, for vaccine-associated myocarditis, most cases are in adolescents and young adults, with males greater than females. And then for viral myocarditis, incidence in males greater than females. Male incidence peaks in adolescence and gradually declines. Symptom onset with vaccine-associated myocarditis typically clusters within a few days after vaccination, and most cases occurring within a week. With viral myocarditis, symptom onset occurring within 1 to 4 weeks after viral illness. The next characteristics get at clinical severity of disease, and the general picture is that myocarditis associated with mRNA vaccination relative to viral myocarditis tends to be clinically mild, and patients have good prognosis and a fairly short recovery period. Next slide. So now we'll get into the reports of myocarditis after Pfizer vaccination among children ages 5 to 11 years. And through the analytic period, there are 64 preliminary reports of myocarditis. 4 remain under review. 40 did not meet case definition for reasons like misclassification. They were preliminarily determined to be MIS-C, or symptoms were present but did not meet definition. So that leaves us with 20 cases, myocarditis cases, that met CDC case definition. Next slide. Of these 20 reports, the median age was 9 years, with an interquartile range of 7 to 10 years. Median time to symptom onset after vaccination was 3 days, with an IQR of 2 to 3 days. There were 4 reports with symptom onset greater than 7 days after vaccination. Those were at 8, 11, 12, and 12. 14 of the 20 reports occurred after dose 2. 15 of the 20 reports were in males, and 17 of the 20 reports were hospitalized. The remaining 3 were treated as outpatients. 14 of the 17 of the hospitalized patients had recovered from symptoms at the time of the VAERS report. None of these cases reported a vaccination error involving receipt of an adult dose. These 20 cases, there was 1 report with a history of viral prodrome 3 to 4 days prior to onset of myocarditis symptoms, 3 with current COVID-19 disease at the time of symptom onset, and no reports with a documented history of COVID disease prior to symptom onset. There was 1 death in a male child with onset of fever 12 days after dose 1, and abdominal pain, vomiting, and death the following day. That would be day 13 after dose 1. This patient had a rapid clinical course from the time they started experiencing their abdominal pain, day 13 after dose 1, till the time they were brought into the ED and subsequently died, was on the order of a couple hours. Histopathological evidence of myocarditis was present on autopsy, and that was felt to be the cause of death. Testing, which included testing done by the infectious disease pathology branch here at CDC did not find evidence of viral infection at the time of death, and CDC continues to assist with case review. Slide. Next slide, please. Here's a figure showing the ages of these cases. This does not take doses administered into consideration. These are just counts, but you can see, at least visually, that there appear to be more counts towards the older side of this age spectrum, 5 to 11 years. Next slide. This is a table of VAERS reporting rates per million doses administered after Pfizer vaccine in the days 0 to 7 after vaccination. Again, the focus of this presentation is on children ages 5 to 11, but I'm showing you the other ages for reference. And if we just focus on those other ages for reference to start off with, you'll see the pattern that I explained previously for myocarditis associated with mRNA COVID-19 vaccination. Cases are mostly in males, with more cases after dose 2. The reporting rate peaks both in males and in females in the 16 to 17-year-old age group, and then gradually declines as individuals get older. Where the cells are shaded in peach, that means that the reporting rate exceeded the background rate that we estimate from the literature. And then just looking at the age group, 5 to 11 years, you'll see that the only cell where the reporting rate exceeds the background rate is in males after dose 2, where we have a reporting rate of 2.7 cases per million doses administered. And that is slightly above the upper bound of the background incidence, which ranges from 0.2 to 2.2 per million doses administered. Next slide. So what we've done here is to add in the reporting rates for the 8 to 21 days after vaccination. The data in the 0 to 7 days has not changed from the previous slide. So this is to illustrate the point that for vaccine or for myocarditis associated with vaccination, we believe that these cases tend to cluster very close in time after vaccination, again, usually within a few days, mostly within 7 days. And you can see that the reporting rates in the 8 to 21 days, both for males and for females, none of those exceed the background incidence. We also have data from VSD, which has been the Vaccine Safety Data Link, which has been presented previously, showing statistically significant clustering within several days after vaccination. And in VSD, when looking at excess risk in the 0 to 21 days and in the 0 to 7 days, nearly all of the excess risk is occurring in the 0 to 7 days. So, I mean, based on the evidence we have, we believe that a reasonable biologically plausible risk interval for vaccine-associated myocarditis is in this 0 to 7 days following a dose of vaccination. Slide. So in summary, since authorization, 18.1 million doses of Pfizer have been administered to children ages 5 to 11 years in the United States. Most reports, 97%, were non-serious. Most frequently reported adverse events for non-serious reports were known and well-characterized adverse events, including potential allergic reactions. The most frequently reported adverse events for serious reports were consistent with MIS-C. There were 20 myocarditis reports verified to meet CDC case definition. There's a male predominance of myocarditis reports, and mostly after dose 2, which is similar to older age groups. There's one death in a male with symptom onset 12 days after dose 1 with a rapid clinical course and histopathologic evidence of myocarditis and autopsy. The reporting rates for males ages 5 to 11 years are lower than for males ages 12 to 15 and 16 to 17 years, especially after dose 2. Reporting rates for males after dose 1 and for females after either dose 1 or dose 2 are within background rates. And CDC will continue to monitor safety among this age group and is following up on case reports of myocarditis to assess functional status and clinical outcomes at least 90 days after onset of myocarditis symptoms. Next slide. Moving on to BSafe, next slide. BSafe is a voluntary CDC smartphone-based monitoring program for COVID-19 safety in the U.S. that uses text messaging and web surveys to check on vaccine recipients in the post-vaccination period. Next slide. Here's a demographic summary of the 49,000 participants ages 5 to 11 who reported a Pfizer vaccination. Next slide. So this is a figure of reactions and health impact events reported at least once in the day 0 to 7 after Pfizer vaccination. Injection site reactions and systemic reactions are commonly reported. And you can see that the general trend is for there to be slightly more self-reports of injection site reactions, systemic reactions, and health impact events after dose 2 compared to dose 1. And that's similar with what we observe in individuals 12 and older in BSafe. Next slide. Slide, please. So these are the top 5 reactions reported at least once in the 0 to 7 days after vaccination. Injection site pain, fatigue, headache, and fever and myalgia are all fairly commonly reported. And again, slightly more reporting after dose 2 compared to dose 1, which is similar to what we observed in individuals 12 and older. Slide. So in summary, after 49,000 enrollees ages 5 to 7 that have reported Pfizer vaccination, reactions were generally mild to moderate and most frequently reported the day after vaccination. Generally, reactions were more frequently reported after dose 2 than dose 1, and the patterns are generally similar to those observed in people 12 and older. Next slide. Now I'll move on to data from our vaccine safety data link system, which is our EHR-based system used for surveillance and research. Next slide. So the vaccine safety data link conducts rapid cycle analysis to monitor the safety of vaccines weekly using pre-specified outcomes of interest and also to describe uptake of vaccines over time among members. Next slide. These are the pre-specified rapid cycle analysis surveillance outcomes in the settings in which they're monitored. Slide. So for the primary analysis in RCA, the number of outcomes observed in the risk interval after COVID-19 vaccination were compared to the number expected. The expected was derived from vaccinated concurrent comparators who were in a comparison interval after COVID-19 vaccination. So this is a vaccinated versus vaccinated comparison. Next slide. These are the vaccination totals by week for pediatric age groups. And during the analytic period we're looking at, there were 407,000 dose 1s and 378,000 dose 2s in 5 to 11-year-olds. Next slide. There are approximately 877,000 children ages 5 to 11 years in VSD and 786 total doses of Pfizer vaccine administered in this age group. That's 41% of children who have completed the primary series. And there have been no statistical signals for any outcomes identified to date. There have been 10 potential cases of myocarditis or pericarditis identified in the 98 days post-vaccination, 6 of which were verified through chart review. 7-year-old male with acute myocarditis 16 days after dose 1, 11-year-old male with acute pericarditis 19 days after dose 1, and a female aged 9 years with acute pericarditis 14 days after dose 1. The other 3 cases were myocarditis cases within the 0 to 7 day risk interval. 8-year-old male with acute myocarditis 3 days after dose 2. 9-year-old male with acute myocarditis the day of vaccination after dose 2. And a 10-year-old male with acute myocarditis 2 days after dose 2. The remaining 4 were determined not to be cases. Slide. There were 3 verified anaphylaxis cases identified on days 0 to 1 after vaccination. That's the risk interval for anaphylaxis. And that translates into a rate of 3.8 cases per million doses administered of any dose, 4.9 per million for first doses administered, and 2.6 per million for second doses administered. The anaphylaxis rates in children ages 5 to 11 years are consistent with rates observed in people ages 12 and older. Slide. There are 12 potential MIS cases identified after vaccination. We monitor MIS descriptively. 8 were verified as meeting the CDC case definition, and 4 ruled out. 5 of these were male, 6 were following dose 1. All 8 were admitted to the hospital. 5 were admitted to ICU. The median length of stay was 3 days, with a range of 1 to 7 days. The median time from vaccination to symptom onset was 19.5 days. 6 of these 8 cases had both documented COVID-19 infection and COVID-19 vaccination before diagnosis. So 3 with prior infection, then vaccination, then the MISC diagnosis. 1 with vaccination, then infection, then the MISC diagnosis. 2 with unclear timing, but with infection and vaccination prior to MISC diagnosis. And 2 with vaccination, and then a known exposure to COVID-19, and then the MISC diagnosis. Next slide. So overall, the findings from post-authorization safety monitoring of Pfizer primary series vaccinations are generally consistent with those from the clinical trials. Systemic and local reactions are relatively common, with more systemic reactions after dose 2. The reporting rate for myocarditis in bears and males after dose 2 was slightly elevated when compared to background incidence. Otherwise, reporting rates are below background incidence. There's no statistical signal for myocarditis observed in VSD rapid cycle analysis. Anaphylaxis rates in children ages 5 to 11 years following Pfizer vaccination are comparable to rates in people ages 12 and older. MISC cases detected in VSD following vaccination had a history of COVID-19 infection or a known exposure to COVID-19 prior to MISC diagnosis. An enhanced safety monitoring continues, including follow-up on recovery status and longer-term outcomes in myocarditis case reports. I want to remind individuals that our clinical immunization safety assessment project is available to perform clinical case consultations for U.S. healthcare providers with complex cases of adverse events following immunization. Next slide. I especially want to remind our public health partners and our healthcare partners in practice that we need your help in enrolling children into VSafe, particularly as younger children may be vaccinated coming up soon. This basically requires parents to enroll their children. And as far as how can healthcare providers help us with this process, please provide VSafe information sheets to the patients, parents and patients. Ideally, this should occur prior to vaccination for young children. Please display posters of VSafe and direct patients to vsafe.cdc.gov to enroll. We need your help in this process, and this is a very important way that we collect information early on as the vaccination program is rolling out. Next slide. I'd like to acknowledge the following groups for their contributions to vaccine safety monitoring. Next slide. Next slide. That concludes my presentation. I'll be happy to take questions.
Thank you, Dr. Shimapakura. Actually, I think what we're going to do is we're going to ask our colleagues in the CDC room to switch over to Dr. Talbot's presentation, and we'll take questions on both your presentations at the end. I actually want, as you're transitioning to Dr. Talbot's presentation, I know Dr. Alt has been able to join and joined a little while ago. I am hoping he might be able to announce himself. And Dr. Alt, if you can state your name, your affiliation, and whether you have any conflicts of interest, we'd appreciate it.
My name is Kevin Alt, and I'm an obstetrician gynecologist at the University of Kansas Hospital in Kansas City, Kansas. I have no conflicts. My participation in the meeting today is probably going to be limited because I have clinical duties today.
Thank you, Dr. Alt. We appreciate you joining for whenever you can. Terrific. Are we ready to go for Dr. Talbot's presentation?
Slides are up. It looks good.
Okay, perfect. Thanks, Dr. Talbot. Go ahead.
Okay, so I'm presenting on behalf of myself and Dr. Hopkins, who's the NVAC chair for VAST. VAST stands for the Vaccine Technical Work Group, and this will be a summary of what we have reviewed and our assessments of that. Next slide, please. So this is a reminder. The objectives of VAST include the following: review, evaluate, and interpret post-authorization and approval COVID-19 vaccination safety data. To serve as the central hub for technical subject matter expertise from federal agencies conducting post-authorization approval and safety monitoring. Advise on analyses, interpretation, and presentation of vaccine safety data. Provide updates to the ACIP COVID-19 vaccines work group and the entire ACIP on COVID-19 vaccine safety. We've had meetings almost weekly since December 21st. In total, there have been 57 meetings to review vaccine safety data. Next slide. So this report will cover the assessment of boosters in children. Let me restart again. This assessment was done in preparation to discuss the booster dose in 5 to 11-year-olds. So specifically, VAST reviewed the most recent data from the 3 U.S. safety monitoring systems, which include VAERS, VSafe, and VSD. Safety after the primary vaccination series in 5 to 11-year-olds was reviewed, and then safety after booster doses in 12 to 15-year-olds were reviewed. And that's because that is the youngest age group for which boosters have been previously authorized. 18.1 million doses of Pfizer BioNTech have been administered to children ages 5 to 11 years of age. In VAERS, reporting rate for myocarditis among males is lower in those ages 5 to 11 than in those 12 to 15 years of age. In the VSD rapid cycle analysis, at this time, there's no statistical safety signals after over 700,000 doses have been given in children 5 to 11 years of age. Therefore, data do not suggest potential safety concerns regarding a Pfizer BioNTech COVID-19 vaccine booster for children 5 to 11 years of age beyond those previously identified in older age groups. Next slide. I'm going to change topics slightly. VAST decided to review how mortality was followed and assessed following COVID-19 vaccination. The CDC Immunization Safety Office and FDA have a standard and systemic methods for following up on all reported deaths following vaccination. Because of the importance of mortality as a potential adverse event following vaccination, VAST has reviewed mortality data as available from several systems. Population-based studies conducted to date have not identified increased risk of death following COVID-19 vaccination. Spontaneous reporting to VAERS has not identified any unusual reporting or patterns of causes of death. Next slide. In a cohort of 6.4 million COVID-19 vaccinees and 4.6 demographically similar unvaccinated persons, no increased risk of mortality was seen among COVID-19 vaccine recipients. Among 20,000 nursing home residents in 284 facilities, no increase in 7-day mortality was seen following COVID-19 vaccination. Among deaths reported to VAERS following COVID-19 vaccination, Bayesian data mining identified no signal other than mortality due to COVID-19 vaccine disease, which would be vaccine failure following adenovirus 26 COVID-2 vaccine. No unusual clustering of deaths, causes of death were associated with U.S. authorized COVID-19 vaccines. Next slide. The VAS will continue to review vaccine safety data from multiple U.S. safety systems in specific age groups and after primary series and booster doses. We will continue to collaborate with global vaccine safety colleagues on key issues and also our colleagues here in the United States. And we will provide updates to the ACIP work group and ACIP at future meetings. Next slide. I cannot say thank you enough to the members who have attended all of these meetings and given their expert advice, and also all of our ex officio and liaison representatives who have brought data from multiple different monitoring systems in the United States, and especially our co-leads, Lori Markowitz and Melinda Wharton. Thank you.
Thank you, Dr. Talbot. These two presentations are now open for questions, and Dr. Long, I did not forget about you. So if there is a question you'd like to ask Dr. Ruth Link-Ellis, please feel free to go ahead as we're waiting for other hands to be raised.
I think it's going to come up again, after Dr. Oliver's presentation, so I will wait on that one.
Okay, thank you, Dr. Long.
Mm-hmm.
Are there any questions from ACIP members about the safety presentations? Ms. McNally.
Thank you. Just for the benefit of the public, Dr. Shimabukuro, can you describe what it means to complete a chart review?
Well, are you referring to VAERS? Are you referring to the VAERS myocarditis cases?
No, well, perhaps it's helpful in that context too, but I was really talking more about VSD.
Oh, sure. VSD is an electronic health record-based system, so we have complete information on patients from the electronic health record to include vaccination status and to include encounters with the healthcare system and the clinical record and laboratory results. So a chart review is really accessing the electronic health record and abstracting that information and then applying a standardized case definition. For the example of myocarditis, it's applying the CDC case definition for myocarditis and seeing if the information that's available from the medical record is sufficient to verify that that's a myocarditis case. Or if there's information to suggest otherwise, for example, it's not a myocarditis case, or it may be a prevalent case, so it existed before, to make that determination.
Thank you.
Thank you. Dr. Long?
Yes, thanks so much for the data, Dr. Shimabukuro. I'm sorry to have to make you speak because I think it could be painful on your end with your cough. This is kind of a complicated question, but first of all, I would have to say again, as I've said before, although I know you like to have background and you like to compare the rates compared with background rates, viral myocarditis and post-vaccine myopericarditis are very different, as you pointed out, in all of their manifestations. And I think that the myopericarditis post-vaccination is as unique as the cerebral thrombosis and thrombocytopenia. So I'm more likely to look at these events on their face value and the rate of recurrence. So one thing is that although you summarized that the onset of vaccine-associated myopericarditis was maybe at 3 days, I think that your data would show that there are two clusters. One is in the first day or two around vaccination, where I bet the number would be 1, maybe 1 point something post-vaccination. And then there are these stragglers that occur in the second week. So I think I don't know how you decide to justify looking at them differently, but a median of 3 days, I don't think that would be not what most people would present with. So when you have disparate clusters, that makes that a little bit confusing. But my question is this. These vaccinations are not occurring in a void, in a vacuum right now. They're occurring with an enormous rate of infections in children of this age group and slightly older. And what we knew from the early reports of the few cases of myopericarditis that occurred following the first dose, they typically were more likely to be in the second week. And when they were looked at very carefully, many of them were associated with an intercurrent coronavirus SARS-2 infection. And so I wonder if there is any way that we can, I wish the patients would be studied better at the time they appear with their myopericarditis to try to understand, is this vaccine associated pure and simple, which seems to be very predominantly right after dose number 2, or is it associated with vaccine and infection, which is becoming increasingly common, and we might see the rate of myopericarditis higher when we're having an outbreak of lots and lots of disease. That's one thing, if you have any thoughts about that. And the other thing that would be reassuring to me would be to see any data on myopericarditis occurring after a booster dose in that 12 to 17-year-old age group.
To answer your, go ahead.
I was going to say not necessarily that last one in people who had previous myocarditis, that's been reported, but in those who did fine with their first vaccine, 2 doses, and then on the booster dose had their first episode of myopericarditis, because that might be also happening with more intercurrent coronavirus infection. So, sorry, very long thing. I don't know if you can answer any of it, or if you're thinking that there's any merit in thinking about it.
So we did present back in April safety data on booster dose, the first booster dose after the primary series, and there are myocarditis cases that do occur after a booster dose, and there appears to be an increased risk of myocarditis associated with the booster dose, similar to what there is after dose 2 and after dose 1. But the magnitude of the risk appears to be lower, in some cases substantially lower than after dose 2. So that we have that data, and probably we've accumulated additional data since April, so that data is certainly available. We'd be happy to present that on a future call. I think with respect to infection, I'm going to go backwards actually from your third to your second to your first question. But with respect to infection, and I believe we have VSD investigators on the call, I think that it's actually a fairly small percentage of the myocarditis cases that have evidence in the EHR of infection. That's not to say that they weren't infected, because not every case, at least recently, may be captured in the electronic health record. But where we have information, that was a fairly rare event that these cases had prior infection. And then with respect to myocarditis associated with COVID disease, I think that Dr. Matt Oster, who is a pediatric cardiologist, and I believe he's on the call, might be in best position to answer that question. And if Dr. Klein or other VSD folks have anything to add about the rate of prior infection, feel free to jump in.
May I just ask a clarifying question of what you said about, are you saying there were a significant number of children with myopericarditis, for instance, after the first dose or in the second week after any dose, who were investigated by the proper serology to distinguish vaccine from infection, and they were negative, or that they, most people would not do that. Most people would not think about doing that. So are you saying there are significant serologic data that suggest this did not happen, that there was not infection, or that you don't have the data?
No, I can't answer that question. What I can say is that the percentage of cases where there was evidence of infection is pretty low, and I'm actually not aware of sort of a bimodal peak. I think all the data that we have is that these cases, whether it's dose 1 or dose 2, they tend to occur fairly shortly after vaccination, usually within a few days, mostly within a week. Certainly the risk is higher and the rates are higher after dose 2.
You had posed about.
I was going to say the rates are higher after dose 2, but I think the pattern of onset is similar in that they tend to be mostly occur after a week within the first week of vaccination. Matt, I don't know if you were going or if you had a hot mic. Go ahead.
Sorry, can you hear me?
Yes.
Yeah. So cases of myocarditis after vaccine that had an actual COVID infection, while it can sometimes occur, COVID leading to myocarditis, just acute regular myocarditis is pretty rare in the younger age group, meaning adolescents and younger kids, but it can happen. More commonly, as you showed in one of your slides, we do see a number, and there have been a number of VAERS reports of MISC, and some of the myocarditis cases, as you showed, were actually a component of MISC, and we do see that quite often following COVID infection in younger children. But not so much the COVID myocarditis is a bit rarer than the MISC for sure.
Just to clarify I think with Dr. Long, and Dr. Long, you can tell me if I get this wrong, but I think the fundamental nature of the question is when there is a case of myocarditis, independent of what we know about, etiology, sort of what is the routine workup that's typically done? I think the question is, do we have complete information on all the cases? My assumption is we have the information that whoever the frontline clinician happened to be did in terms of their evaluation and workup, but we don't necessarily have the complete information we would always want about every case because these are cases that are being worked up on the front line. Is that your question, Dr. Long?
That is the question, and the second part of it is I'm not suggesting that these are children who have their myopericarditis following vaccination in the second to third to fourth week after vaccination. I'm not suggesting that they have coronavirus myocarditis. I'm suggesting they usually have asymptomatic infection but have a high antibody titer, since we really think this is probably a lot of vaccine antigen or a marker or whatever, spike protein, and in the presence of high antibodies, so that they may have had I'm thinking the cases that I have managed for the Journal of Pediatrics and thought about as we've seen this difference in the first 2 days versus a little later on. And with all due respect, from the rapid cycle analysis, half of the myocarditis cases were in the second week, and only half of them were right after the first dose. So I think there's a variable possibility of what the bad things could happen together that could lead to myopericarditis that may be more common as we're seeing asymptomatic or mildly symptomatic coronavirus infections, and then we're coming back with vaccines. So I've taken enough time. I appreciate you've considered it. And it sounds like we don't have the information we need.
So this is Dr. Klein. I just want to comment quickly. I'm sorry to interrupt. I do want to comment that while half the 5 to 11-year-old cases that we identified were in the first weeks after vaccination, most of those ones later on were pericarditis for the 5 to 11-year-olds. And the younger ones are the ones in the first week were the myocarditis cases. And I do want to reemphasize what Dr. Shimabukuro said, that we have no evidence that we have any clustering past the first week in any of our analysis, both in adolescents for both the primary series and the booster doses for myocarditis, as well as for the older young adults that we've seen in many analyses.
Thank you, Dr. Klein. Thanks for that clarification. Dr. Lair?
So thank you for your presentations. My question is about the relative risk. And I think what many people are wondering is if they were to get COVID vaccine, what's their risk of myocarditis, both for the little kids and also for the adolescents? But if they were to get the COVID disease without having had the vaccine, what's their risk of getting cardiac disease from either directly from myocarditis, pericarditis, or from MISC? And I'm wondering if anyone has that information. Thank you.
Dr. Lee, given your work in that area with the Coronet study, I mean, you and Dr. Oster may be best positioned to answer that question. That's more of a benefit risk type question than a straight vaccine safety question.
Dr. Oster, do you want to go ahead first, and then I'm happy to chime in? Or would you like me to chime in? Either way is fine.
No, I can go. I was trying to pull up so I can give you the actual numbers while I'm doing that on the computer here. But no, that's an excellent question, and we did address this using another data source, the Coronet, as Dr. Shimabukuro alluded to, with a number of investigators at CDC and outside of CDC. And this was published in MMWR on April 8th. To answer just that question, though, what is the risk of overall cardiac complications with COVID-19 infection versus getting vaccination? And we show that for all age groups and all sexes that your risk of getting cardiac complications is certainly higher with getting COVID-19 infection as opposed to, when you get vaccination. That includes, myocarditis, also, MISC, and pericarditis, significant cardiac involvement there. And, even in the highest risk group, obviously, is the teen boys to have the adverse event after vaccination. And even in that group, the risk of heart complications after infection compared to vaccination was 2 to 6 times higher after infection. Does that answer your question?
It does, and I think that's an important point for the general public to recognize and to sort of reemphasize that your risk of these complications are higher with the disease than with the vaccination. Thank you.
Thank you, Dr. Oster and Dr. Lair. I'll only add that, vaccine safety is not in its own bubble. It is, as Dr. Shimabukuro mentioned, it's the benefit risk, and we know that in general, complications after infection seem to lead to more severe disease, and particularly what's been documented in the Israeli study and this particular MMW article that Dr. Oster mentioned focuses on cardiac disease specifically. Are there any additional questions? Okay. With that, we are running a little behind schedule. So I would like to call for a short break before we move to public comment. Dr. Wharton, how much time do you think we'll need to have? Is 5 minutes sufficient, or would you prefer 10?
We'll need 10. We'll have to get the public commenters online.
Thank you. So we'll break and come back at 17 minutes after the hour. Thank you, everyone. Thank you, everyone. It is now 17 minutes after the hour, and we'll reconvene the meeting to begin oral public comment.
Dr. Lee?
I'd like to welcome and thank our public comment speakers today for addressing the committee. All the speakers submitted a request in advance of the meeting, and the final list of public commenters was determined via a lottery. For our speakers today, we have a limited public comment period, and in order to make it through all of the listed speakers, it's extremely important. Each speaker limits his, her, or their remarks to 3 minutes. We will be displaying a timer on the screen so you know how much time you have left. As a reminder, ACIP is very much interested in hearing public comments about the agenda topics being discussed today. Our committee appreciates diverse viewpoints that are respectful in nature and issue-focused. As a reminder, we are asking speakers to share their views about the issues rather than comments about individuals. Thank you again to our speakers, and we look forward to your comments. Let me check in with the room and ask, are we ready to proceed with the public comment speakers?
Dr. Lee, I do not know for sure that we have any of them online yet. Just a moment.
Okay, thank you.
Yeah, you want me to tell her? Oh, hey, Dr. Lee, it's Stephanie. The first 2 or 3 speakers have now logged in if you're ready to proceed.
Okay, great. Thank you. And I see our first speaker for today, if you're able to put up the clock for us, is Ms. Francesca O'Donovan. Ms. O'Donovan, can you please unmute?
Hey, Dr. Lee, it's Stephanie. The first 2 or 3 speakers have now logged in if you're ready to proceed.
Okay, great. Thank you. And I see our first speaker for today, if you're able to put up the clock for us, is Ms. Francesca O'Donovan. Ms. O'Donovan, can you please unmute?
Hey, Dr. Lee, it's Stephanie. The first 2 or 3 speakers have now logged in if you're ready to proceed.
Stephanie, there seems to be a continuous loop.
Yeah, we don't know what.
I don't know if there's a time delay on that end, but we can hear you.
Okay.
Thank you. Ms. O'Donovan, are you able to go ahead?
Yes. Members of the ACIP, my name is Francesca O'Donovan. My husband and I live with our 4-year-old twins in Westchester County, New York, one of the first places impacted by COVID-19 in the spring of 2020. I work in the field of dietetics with a focus on public health and pediatrics. The ban and prohibition of off-label use for the COVID-19 vaccine needs to be removed from the CDC vaccine provider agreement immediately. As members of the ACIP, you are in a position to remove the ban. We know these vaccines are safe. We have real-world data from countries like Germany that have administered tens of thousands of mRNA vaccines to children under 5 with no adverse impact. Children who have medical conditions, like my children, deserve access to a safe and effective vaccine. The unwillingness to act at this point, 2.5 years into a raging, uncontrolled pandemic, is unethical. Children with congenital heart disease, cancer, asthma, metabolic disorders, rare genetic diseases, and are immunocompromised have been left with no options to protect themselves. We need your help to make this change. Moderna submitted their data to the FDA at the end of April, and a VRBPAC meeting is not confirmed. The FDA must move with the same speed as other cohorts, given the gap in vaccine equity. Other cohorts were reviewed between 17 and 21 days. The under 5 population is the most ethnically diverse cohort in the United States. Vaccine inequity is hitting families of color particularly hard. These delays in context of other age cohorts requires justification, not merely it's more complicated. Families need answers. Working families are being disproportionately impacted by this inequity. Parents are hearing through media reports that the FDA is waiting to review Moderna because they want to review it concurrently with Pfizer. This is unacceptable and not based on scientific process. I am asking members of the ACIP to commit to meeting immediately, 1 to 2 days after the VRBPAC concludes the review of Moderna. I am also asking you to voice your support for review based on scientific processes. Over the past 2 months, the hospitalization rates for 0 to 5 are on par with adults. We are approaching 500 cumulative deaths of children under 5. Parents all over the country are facing continued hardship. My children have to go to school. My husband has to go to work. Vaccines are the last line of defense to keep my at-risk children safe. My children, like millions of others, are being exposed to COVID-19 on a daily basis. At this point, we are running off pure luck. Every day matters. End the inequity and protect their future. Thank you.
Thank you for your comment. Next, we have Ms. Dorit Rice.
Can you hear me?
We can. Please go ahead.
Thank you. My name is Dorit Rice, and I'm a professor of law at the University of California, Hastings College of the Law, and a vaccine advocate. Thank you for the opportunity to talk and for your intensive work. I will not address the science behind the boosters, although I appreciate the detailed presentation and how crystal clear it's been made that COVID-19 vaccines are generally very safe is the age group we're talking about, and COVID is obviously dangerous. I want to mention 2 considerations that I hope the committee will consider for boosters that go in different directions, and then I want to say something about the committee procedures. First, to echo the commenter before, there are no vaccines for children under 5 yet. It troubles me, and I think it troubles my colleagues in that age group even more, that we're giving children under 12 a 3rd vaccine while leaving the children under 5 without protection even of the basic series. Although much of this is not under the committee's control, I hope you keep the little one in mind and prioritize them once you can give them the vaccine. Second, as you know, your decision has implications beyond recommending to doctors what to do, because your decision directly affects finances and what insurance covers. It's not as clear as long as COVID-19 vaccines are supplied by the government, but at some point that funding will end, and that will raise questions of access, because insurance company will cover vaccine you recommend, but not others. At the very least, I can think of 2 groups that may have access issues. Children with conditions that make COVID-19 more dangerous and the vaccines less effective. And again, I hope you consider that your recommendation may allow or deny access to those 5 to 11-year-olds, and travelers, as other countries who have access to vaccines may require boosters from that age group, and not having access to a booster may limit travel. Finally, I have a suggestion to your hard-working committee staff, which thank you for all your work. I know it's been a very rough 2 years. And my suggestion is aimed at making public comment more meaningful. This is assuming the committee intends to keep allowing oral comment, and I suggest, again, that you may consider whether it's a good idea, since if the main use of the comment is to make anti-vaccine propaganda videos, that's not a legitimate call of public participation. But as long as we have them, when there's an emergency meeting, it makes sense that the agenda will only come up shortly before because there's no time. However, you know the big topics of the meeting well in advance, or at least somewhat in advance. When you put up the announcement of the meeting, it's a good idea to put the topic in a short format. For this one, you could have said, ACIP will meet to discuss 5 to 11 boosters, and that can help commentators know whether to comment and what to focus on. Thank you very much for your hard work.
Thank you for your comment. Next, we have Pamela Kavanaugh. Is Pamela Kavanaugh on the line?
Yes, I'm here.
Okay, thank you. Please go ahead.
Hello. I want to acknowledge to the committee that I attest that I have no financial conflicts of interest. My name is Pam Kavanaugh. I am a mother, grandmother, and I'm COVID vaccine injured. I have multiple neurological issues from Moderna vaccine I received in March of 2021. I reported over 32 symptoms, and I've seen over 26 medical providers. I reported my injury to VAERS, and I have heard nothing back from them. In my search for healing, I have come across many other individuals with debilitating neurological adverse reactions to the COVID vaccine products. I am one of the founding members of the COVID Vaccine Injured of Washington State, or CVI of Washington. We are an independent, nonpartisan group of COVID vaccine injured individuals who are advocating for acknowledgement of the injured in Washington State. We have met with the offices of several members of Congress in our state and have done multiple media interviews in respected publications and medical journals such as the British Medical Journal. Due to the intentional suppression of our reactions by the CDC, FDA, and social media outlets, the injured are unable to find support and access essential medical care. There is no funding for research, and there is no recovery plan or financial support available for us because the COVID vaccine products are not eligible for the VICP program, unlike every other vaccine on the market. As of May 1st, the CICP has received 5,033 injuries or death claims from the COVID vaccine products and has yet to pay out a single cent. By contrast, Thailand's National Health Security Office reports compensating over 14,000 people around $50 million to settle COVID vaccine injury claims. Again, by contrast, the U.S. has paid out nothing. We were asked to protect others by getting this vaccine, only to find out there is no support or protection for us in return. We can't even get acknowledgement. The total vaccine injury filed for VAERS database as of May 6, 2020 was 856,340, and we know that only 1 to 10% of injuries are reported to that system. CDC, we need you to acknowledge us. Without the acknowledgement from the CDC of our injuries, proof of causation cannot be met. In many cases, doctors refuse to believe us or treat us. Without your acknowledgement of our injuries, trusting parents will continue to vaccinate their children not knowing the possibilities of the real horrible adverse side reactions that are being suppressed. Taking care of people who have been injured by the COVID vaccine is simply the right thing to do. It should not be a polarized issue. For information from our organization, or if you're a COVID vaccine injured in Washington State, please visit cviwa.org. Thank you.
Thank you for your comment. Next, we have Joan Edelstein.
Thank you. I'm Joan Edelstein, Professor of Nursing Emeritus, still teaching both public health nursing and school nursing in the California State University system, and a longtime vaccine advocate, having been in nursing since well before many of the vaccines to prevent diseases and death in children were developed. I greatly appreciate the opportunity to speak and certainly appreciate the critical work that you do. I've had the honor to previously speak to the committee about the essential role of school nurses caring for the pediatric public health population in effectively carrying out the recommendations of this committee. Recommendations for vaccines for children are evidence-based. COVID vaccines have been recommended for children 5 and up, and hopefully soon to be recommended for younger children. Also evidence-based, as recognized by the CDC, is the role of school-located vaccine clinics, partnering with public health departments and or community agencies in increasing vaccine uptake both in children and their families, and to promote vaccine confidence. The CDC website highlights Los Angeles Unified School District and East Hartford High School as success stories. School nurses are responsible for the entire health program of school districts and are often the only healthcare professionals employed by the school district. Additional success stories in California are COVID vaccine clinics in Orange County, the evidence-based Chew the Flu vaccine clinics from our local public health department, and school nurses at many school districts where vaccine uptake for their underserved students and families were greatly increased through their collaboration with local pharmacies, including helping to enroll in VSafe. Resources are available to all school districts. The president of the National Association of School Nurses has access to presidents of each state chapter and to school nurses across the country. The National Association of County and City Health Officials has a comprehensive toolkit for everything needed to set up school-located vaccine clinics on their website. We have the resources in place for school-located vaccine clinics. We have school nurse experts available across the country who have modeled these successes. What we need now is for this committee and the CDC to provide recommendations and guidance to engage school nurses as trusted messengers to implement these recommendations. Talk to the school nurses, give them the voice they need to keep our children and their families healthy. Thank you.
Thank you for your comment. Next, we have Dr. Andrea Klein-Tilford.
Greetings. I am Dr. Andrea Klein-Tilford. I'm a pediatric nurse practitioner and the president of the National Association of Pediatric Nurse Practitioners, a professional organization representing more than 8,000 pediatric-focused nurse practitioners. We support the timely and complete immunization, including boosters, of all infants, children, and adults to maximize the health and well-being of all people. Children can and do suffer acute illness, multisystem inflammatory syndrome, long-haul physical symptoms from COVID-19, and yes, even death. Deaths in children from COVID have been far greater than from diseases such as influenza and measles, for which we have vaccines. Evidence demonstrates that COVID-19 vaccinations in children 5 years and up have significantly reduced hospitalization rates and nearly eliminated intensive care unit stays for fully vaccinated children. Approximately 29% of children 5 to 11 years of age are fully vaccinated, leaving significant work left to do in counseling families to have their eligible children vaccinated against COVID-19. As frontline healthcare providers, pediatric-focused nurse practitioners highly value evidence-based strategies that will help mitigate the spread of COVID-19 and end the pandemic. We appreciate the FDA's authorization of a booster third dose of the Pfizer-BioNTech vaccine for children 5 to 11 who have received their initial 2-dose vaccine at least 5 months ago. Boosters are critical to increase antibodies, to improve immunity, and further protect children, which is a key to improving our overall public health. Numerous studies have shown that children of all ages have suffered mental and behavioral health challenges during the pandemic. There has been an alarming increase in child and adolescent anxiety, depression, and suicide. By using every possible mitigation tactic to stop COVID-19 infection and spread, we are improving this generation's physical and mental health well-being. Based on available data, the COVID-19 vaccine booster is safe and effective and is essential in keeping children healthy, thriving, learning, participating in extracurricular activities, and out of the hospital. NAPNAP urges the ACIP to approve the Pfizer-BioNTech COVID-19 booster for all eligible children 5 to 11 years and supports widespread equitable access and administration. It is essential for all individuals eligible for vaccination to receive and remain current with COVID-19 vaccines, including boosters. Finally, it is critical that the FDA swiftly and thoroughly review and approve the COVID-19 vaccine for children less than 5 years of age. As the newest Omicron variant continues to rise across the country, these families feel forgotten, and without mask mandates, they are left with little protection for the youngest children. Thank you for this time to share the views of the National Association of Pediatric Nurse Practitioners and my own views as a mother of 2 children 12 years of age and under.
Thank you for your comments. Next, we have Mrs. Christine Asher.
Hello. Can you hear me?
We can. Please go ahead.
Okay. My name is Christine Asher. I'm an office manager in California and a mother to 8 children, 4 of them being school age. I was healthy, active, and always on the go with my large family. When the vaccine came out, I was excited. I advocated and pushed for family, friends, and employees to get immunized. I drove over an hour to get my shot and do my part. 20 minutes after my second shot of Pfizer, my heart rate took off, my limbs went ice cold, and I had severe brain fog to the point I felt drunk. I was told at the vaccine clinic that what I was experiencing was anxiety. I felt like I was going to pass out, but I stumbled to my car and went home. 4 hours later, I went to the hospital because my symptoms were getting worse. Again, told that what I was experiencing was anxiety. This anxiety diagnosis continued for over a year while my health declined and I became unable to even get out of bed. The symptom list grew and my heart rate was over 200 often. I reached out for help by contacting VAERS, Pfizer, and the CDC. I learned quickly that once you are injured, there is no help and no type of recourse that can be taken. The silence from Pfizer and from the CD was loud and profound. Over a year later, after countless doctors, hospital visits, and astronomical medical bills, I was finally diagnosed with dysautonomia and autoimmune disease. Unwillingly, I had become a member of the vaccine-injured community, an alarmingly growing community that is being tossed aside and ignored. The CDC and the vaccine manufacturers are not addressing the problem or helping in any way. We need the CDC, vaccine manufacturers, and medical community to recognize the phenomenon happening. I am not anti-vax, and this is not a political issue. I am a human being, so are the tens of thousands of others that have had a reaction. This is a humanity issue, and we are being ignored with no help offered. We suffer alone until we find each other through social media. Then we are silenced again or flagged as misinformation. Until this vaccine and the harm it is causing is researched more and you are able to address the health and the injured that are already suffering, the vaccine agenda should stop. I feel it is not only morally wrong, but a gross negligence to innocent people around the world. People should have informed consent and know that the possibility of having a lifelong reaction is real. The CDC needs to acknowledge the people injured and suffering and help us find out why this has happened and what treatment can be done to help, if any. Please stop ignoring the injured. We did our part. Please help us. There are more than just us that are suffering. There are children, people of all ages. We are just asking for help. Thank you.
Thank you for your comment. Next, we have Mr. Stephen Kirsch.
Hi, my name is Steve Kirsch. I'm Executive Director of the Vaccine Safety Research Foundation. I have no conflicts. I urge you to approve, not to approve the boosters because we now have new direct observational data that shows very clearly that the vaccine is killing more kids than it saves. Someone needs to mute, please. Can you stop my time, please?
Please go ahead.
Okay, thank you. I appreciate that. But you should not take my word for it, just like you shouldn't take their word for it. There's a simple reality check that every member of the committee should do before this vote to find out who is telling you the truth. And you must do this research because the CDC death data for those under 25 is not complete for any date after January 2021. And the CDC death data does not indicate suspected COVID vaccine deaths. There's no post-marketing data on this. Do any of you know what the various underreporting factor is and how it was calculated? Why not? According to the CDC's own methodology, it's over 40. Why have they never told you that? In short, the government has not provided you with the key data you need to make a proper risk-benefit analysis. They have assumed that the vaccines haven't caused a single death. That simply isn't true. And now you can prove it for yourself, just like I did recently using the adult death data, which includes vaccination status. The result is highly statistically significant and has not been disputed. I have made the data publicly available so anyone can replicate this. The best way to get the data that you need is to do your own post-marketing survey. Fortunately, there's an easy way for you to do this. Here's what I did. I have hundreds of thousands of followers on social media. I asked my followers, do you know any kids who have died since January 2021? Since January 2020, how many have died from COVID? How many might have died from the vaccine? Recall shouldn't be a significant bias because the child death from either COVID or the vaccine is an event nobody forgets. So even if there's a bias towards recalling more recent events, the bias affects both options equally. If recall is high for these events and the vaccines have the same kill rate, we'd expect to have 4 times as many COVID deaths reported than vaccine deaths since the time period was more than 4 times larger. And if the CDC is correct that the mRNA vaccines haven't caused any deaths, the numbers should be lopsided with dozens of COVID deaths and 0 vaccine deaths. What I found was the exact opposite. There were 0 reported deaths from COVID, but there were 11 deaths that were judged to be vaccine-related. All 11 deaths were in previously healthy kids. 40% of the deaths happened in the first 7 days after vaccination. How do you explain that? If you cannot explain that, you cannot approve the boosters today. Please replicate this study for yourself or contact me for the names and all the data. I'm happy to share the details of all of this so you can do your own independent investigation, including viewing the autopsy reports, which are available for at least 40% of the deaths. None of these deaths were reported to the VAERS system, suggesting that the VAERS deaths are underreported by at least a factor of 10. If you cannot explain the result that I got, you should not approve these vaccines at this time. The data I was interrupted. The data I received. I'll give you
a little extra time, Mr. Kirsch. I'll give you just a few more seconds to wrap up. Thank you.
Thank you, Dr. Lee. I appreciate that. The data that I received clearly shows the vaccines are doing more harm than good in this age group. There is simply no other way to explain the data. Do you want to see the data and talk to the parents before your vote today?
Your time has ended. We really appreciate it, and apologies for the interruption.
Thank you.
Next, we'll move on to Ms. Lauren Dunnington.
Sorry, there we go. Hello and thank you. My name is Lauren Dunnington. I work in global public health and I have 2 children under 5 in Washington State. The message I want to share today is one of urgency for children under 5 in the U.S. We're seeing another surge of new cases across the country, the emergence of new Omicron variants of concern, and where I live in Pierce County, the local health department has reported 11 daycare outbreaks of COVID-19 just in the last week. Like millions of working parents, I send my kids to daycare every day wondering, is this the day they will bring home another COVID-19 infection? You see, there are 19 million children under 5 who, as of today, are the only group in the U.S. who do not have access to COVID-19 vaccines. Half of these kids belong to underrepresented groups that have been disproportionately affected by the COVID-19 pandemic. Working parents, especially those who are low income, have few options to protect children now that prevention measures like mask mandates have ended all across the country. Every single day that kids have to wait for these vaccines is one more day for a kid to get sick. CDC has reported 491 deaths of children under 5 due to COVID-19, but children should not die from a vaccine-preventable illness. Over the past 2 months, COVID hospitalization rates for children under 5 have trended closely with hospitalization rates of adults 18 to 49, and under 5s are being hospitalized more often than children over 5. As a parent, I'm also concerned about COVID-19 sequelae. We've seen increased incidence of diabetes, multisystem inflammatory syndrome, myocarditis, long COVID, and even potentially hepatitis. We know these mRNA vaccines are safe and effective and that they prevent severe outcomes from COVID-19. In fact, 9 million kids over 5 have received an mRNA COVID vaccine in the United States, and in Germany, tens of thousands of under 5s have already been safely vaccinated. I was thrilled to hear that Moderna submitted a full emergency use authorization package that included under 5s to the FDA on May 9th. However, my excitement went away when I saw the FDA would not meet to review this data until June. For every other age cohort, the FDA has convened a VRBPAC meeting within 21 days of EUA submission. So what is the delay for reviewing the Moderna data for under 5s before the end of May? My own daughter is 4.5. She and her age mates across the U.S. are preparing to start kindergarten in the fall, but for a safer start, we need our kids to complete a full vaccine series before the school year begins. Time is running out for these kids. I implore the FDA to prioritize vaccine access for our youngest children first, and I ask ACIP members to use your own powerful voices to push for a faster timeline for FDA approval. I understand that FDA approval has to come first, but I would like reassurance that the ACIP will act swiftly and meet as soon as possible within 1 to 2 days of FDA approval to authorize vaccine for under 5s. The clock is ticking. Moderna met immunobridging criteria. Please do the right thing by our kids and approve the Moderna vaccine as soon as possible. Every day matters. Thank you.
Thank you for your comments. Next, we'll move to Dr. Kaylee Solar.
Hello, and thank you so much for giving me the time to speak today. My name is Kaylee Solar. I am a PhD chemist, so not a physician, but a PhD chemist trained in reading and analyzing scientific data and scientific articles, and I've been following the work that the ACIP and the FDA has been doing to approve vaccines since the very beginning of the pandemic, very excitedly, and so happy that you're meeting today to approve boosters for 5 to 11-year-old children. What I wanted to speak with you today is the urgency around the children under 5 who have no access to a vaccine at all. Every other age group has access to at least one vaccine, regardless of if it's a booster or not. And what we really need to focus on here is the urgency around getting a COVID vaccine available for children under 5. I have 2 things that I want to ask you to do immediately today, because it truly seems like to us parents of children under 5 that these children have been forgotten. Mask measures have been removed across the country. People are going back to work, they're going back to normal, and our children are still left completely unprotected. How has this happened where it seems as though our youngest generation has been completely forgotten? What I would ask for you today is 2 things. Number 1 is to figure out who can approve off-label use of the current vaccines and work together to get this approved. These vaccines are safe. We know that people in Germany are vaccinating children under 5 with these vaccines and having great outcomes. I would encourage you to look for this real-world clinical evidence data and allow off-label usage in the U.S. as well, especially for kids that are high risk under 5. They have no options at this point and they need some. Number two, something that Lauren mentioned as well, which is please, please use your strong voices and work with your FDA colleagues to move up the review of the Moderna's data to approve the vaccine for children under 5. We've seen a great deal of urgency around the approval for the vaccines for the other age groups, and I would only ask that this group of children under 5 receive that same level of urgency. We understand that it's very important to make sure that these vaccines are safe and effective, but we also know that the review can happen quickly as they did for the other groups. Please work with your colleagues at the FDA to move up this date of review. We even heard when these dates were originally published that if the data was received earlier, that they would move up the dates. So please let's hold ourselves to that promise and move up those review dates so that children under 5 can have access to a vaccine as soon as possible. The other thing I just wanted to comment on here is around what I heard today, and it's that people who don't want their children to be vaccinated can continue to choose to do that. They can choose to not get their children vaccinated. I am desperate to get my child vaccinated against COVID because I am terrified of her getting COVID, and I'm not terrified of these vaccines. I should be able to have the choice to vaccinate my child rather than her getting COVID. And so truly in the risk-benefit analysis that I have, it would be that she get vaccinated rather than getting COVID. Thank you.
Thank you for your comment. And that was our final public comment speaker. I want to thank everyone again for your public comments. We truly appreciate everyone who contributes to the meeting through both written and oral public comments. We now need to move on to the next session. So if we could please put up the next set of slides. I'd like to introduce Dr. Charu Sabharwal from Pfizer, who will review the safety and immunogenicity data for the BNT162b2 booster, 10 microgram booster dose in children ages 5 to 11 years. Dr. Sabharwal?
Thank you, Dr. Lee. Are you able to hear me?
We can. Please go ahead.
Wonderful. If we can go to the next slide, please. So on behalf of the entire C4591007 Pediatric COVID-19 vaccine team, I appreciate the opportunity to review the safety and immunogenicity of the booster dose of BNT162b2 at the 10 microgram dose in 5 to less than 12-year-olds. In this presentation, I'll review the following booster data that was agreed upon with the FDA to support this authorization. Safety and tolerability assessments in 401 participants with follow-up from dose 3 to 1 month post-dose 3. And for the immunogenicity, the first 130 participants to complete 1 month post-dose 3 by March 15th, 2022 contributed to the overall descriptive immunogenicity assessment. Immune responses against the SARS-CoV-2 wild type were assessed from these participants who completed 1 month post-dose 3. And an additional 67 participants from our 2-dose series population were included to conduct a robust 1 month post-dose 2 comparison. I'll provide further details in the coming slides. In addition, for the 130 participants who completed that 1 month post-dose 3, 30 of those participants also completed 1 month post-dose 2, for which I'll describe a supportive immunogenicity analysis conducted against the Omicron variant. If we can go to the next slide, I'd like to take a moment to review. Perfect, thank you. I'd like to take a moment to review the study design related to the 1 month post-dose 2 and 1 month post-dose 3 as they're critical to this analysis, as denoted by the first line with the associated key time points on the second line. Originally, this was a placebo-controlled observer-blinded study evaluating the 2-dose primary series, as you can see in the first line. And on June 7th, 2021, the phase 2/3 2-dose series was initiated. Enrollment was completed on September 10th, 2021, with approximately 4,500 participants randomized in a 2-to-1 ratio to achieve a safety database of 3,000 actively vaccinated. As you're aware, on 29th of October 2021, an EUA authorization was expanded to include this group based on immunogenicity and safety, as well as descriptive efficacy. The immunogenicity criteria, or our primary immunogenicity objective, was to immunobridge the immune response elicited by those participants in this age group to that of the participants in the 16 to 25-year-old age group of the landmark efficacy trial up to 1 month after the second dose. I raise that to you because only 450 of the randomly selected participants in the trial had that 1 month post-dose 2 blood draw. With the EUA authorization, participants in this age group became eligible for unblinding. On January 4th, 2022, the protocol was amended to include a third dose for all participants to maximize protection against variants of concern, including Delta and Omicron. On January 31st, 2022, booster doses were initiated in this age group among our existing participants, and as noted in the red box, you can see dose 3 followed by 1 month post-dose 3, or to the data cutoff period of March 22nd, 2022. Next slide, please. Of the 401 participants who received the booster dose at the 10 microgram dose, the demographics were overall representative of participants in the trial. As noted, more than 50% male, 70% white, 7% African American or Black, 12% multiracial, 23% Hispanic with a mean age of 8 at the time of dose 1. And as you can see as you go down, that none of these participants at that time reported a history of COVID-19, but 5.5% did have a baseline positive test for SARS-CoV-2. Next slide. The follow-up time for the booster dose is shown in this table, with most occurring 8 to 9 months after dose 2, and as you can see, the range is from 5 to 9 months. Slide, please. The dose 3 mean follow-up time in the table as listed below is 1.3 months. I'll now move into the safety discussion. If we go to the next slide, please. And after that too, thank you. Perfect. So in the next 2 slides, I'll review reactogenicity, local on this slide and systemic on the next. So let me take a moment to orient you, as this slide does include reactogenicity for 7 days after each of the 3 doses, provided in a side-by-side comparison. In green is mild, in blue is moderate, in gray is severe, and as the gray line is difficult to see, I provided the numbers at the top of those bars for you. In red is grade 4 events, and as you can see, there were no grade 4 events that occurred. Pain at the injection site was the most commonly reported, with most local reactions being mild or moderate in severity. And as you can see, severe reactions were infrequent and occurred at less than 1%. The median onset for all local reactions after any dose of BNT162b2 10 micrograms was 1 to 2 days, and all events resolved with a median duration of 1 to 2 days after onset. As we go into the next slide, we review the systemic events, which again displays all 3 doses side by side. Like local reactions, most reactions of systemic events were mild to moderate. If you look at the second and the third column, fatigue and headache were the most commonly reported across the 3 doses. And if we look at the first column, overall the rates of fever were low, and you can see no red bar, meaning there were no fevers greater than 40 degrees centigrade. In addition, in the fourth column, you can see chills also remained low. Throughout our systemic events, there were no grade 4 events at dose 3, and severe reactions remained infrequent and occurred at less than 2%. If we move to the next slide, I'll discuss the adverse events. The overall number of AEs were small, with 9% of participants reporting an adverse event. 4.7 were reported to be related, of which most were related to reactogenicity events, and I'll walk you through that in the next slide. And as you can see in the rest of the slide, there were no serious adverse events. Sorry, it was one more moment. If we go back, there were no SAEs, related SAEs, withdrawals due to adverse events or deaths, which was consistent with our 2-dose series data. Next slide, please. This slide now provides a breakdown of the 9% of adverse events that occurred from dose 3 to 1 month after dose 3 that occurred in greater than 1% by system organ class. Overall, these events were either consistent with reactogenicity events, and I've highlighted that in gray for you by the system organ class. As you can see, general disorders, gastrointestinal disorders, and nervous system disorders. In the footnote at the bottom, it describes the reactogenicity listed. The other events that comprise this group were infections, illness, and injuries typically observed in this age group. The one last system organ class that I'd like to review with you is the blood and lymphatic systems disorders, and we'll go through that in the coming slides. So if we can move on to the next slide, please. Or after that. Perfect. So few adverse events clinical interest corresponding to those requested by the FDA or CDC list of AESIs. None of the following were reported in our BNT recipients from dose 1 up to the data cutoff point already described. We did not have any cases of anaphylaxis, myocarditis, pericarditis, Bell's palsy, or appendicitis. From dose 3 to cutoff, we did have one event of rash. It was a mild facial rash considered unrelated to vaccine by the investigator, attributable to wearing a face mask. The onset was 11 days post-dose 3 and resolved 4 days later. If we go into the next slide, I'd like to discuss with you lymphadenopathy that was seen in this age group, including axillary mass and a palpable node. We did observe it in this 5 to less than 12-year-old age group, but as I'll describe, it was lower in frequency compared to adults with a third dose of BNT162b2 at the 30 microgram dose. Overall, post-dose 3, as you can see here, there were 10 participants, or 2.5% of BNT162b2 participants. This was slightly higher than what we saw at post-dose 2, but lower in frequency compared to post-dose 3 adults at the 30 microgram dose at 5.2%. Overall, these events were mild, and they were considered to be related by the investigator. They did occur primarily in the axillary or cervical nodes, and the onset was within 2 days of booster vaccination. They were reported as resolved within 1 week of onset. With that, I'd like to come to my overall safety conclusions. That the safety from 401 participants who received a booster third dose of BNT162b2 at the 10 microgram dose did not identify any new safety concerns. Reactogenicity was mostly mild to moderate and short-lived after the third dose, and generally comparable to that observed after the second dose. As mentioned, the adverse events of special interest were limited to the 1 case of rash. Now I'd like to move on to the immunogenicity for you, and like to go into the next slide. At a high level, this was a descriptive immunogenicity analysis that compared the immune responses at 1 month post-dose 3 to 1 month post-dose 2. As I mentioned at the start of this talk, not all participants in the trial had a blood draw at 1 month post-dose 2. I'd like to walk you through these 2 boxes, the 3-dose set and the 2-dose set. As mentioned, 130 participants did complete 1 month post-dose 3 by March 15th. Of the 130, 123 received the 10 microgram dose. These participants were with and without evidence of infection. As mentioned already, 30 of those participants were part of our 1 month post-dose 2 immunobridging subset. As we sought to make this evaluation in those participants without evidence of infection, of the 103 participants who completed 1 month post-dose 3, 67 did not have evidence of infection, and for the 30, 29 did not have evidence of infection. In addition, as mentioned, the 2-dose set included an additional 67 participants without evidence of infection who were randomly selected from our 1 month post-dose 2 evaluable population. I'd like to now go into the actual data. If we go to the next slide, I'd like to orient you to the graph first, as it shows 4 time points going left to right: before dose 1, 1 month post-dose 2, before dose 3, and 1 month post-dose 3. At the bottom of each bar are the number of participants without evidence of infection included from those 2 sets I discussed, the 3-dose and the 2-dose set. Among participants without evidence of infection using the combined 2-dose and 3-dose sets, you can see that there are substantial increases in the SARS-CoV-2 neutralizing titers against wild type after dose 3, seen in the blue bar, compared to after dose 2 in the dark purple bar. The geometric mean ratio comparing 1 month post-dose 3 to 1 month post-dose 2 was 2.17. In addition, the overall geometric mean titers and geometric mean ratios were similar to this in participants when we included those with and without evidence of infection. Moving on to the next table, as with the prior slide, This looks at participants without evidence of infection, again using the 2-dose and the 3-dose set. High seroresponses against SARS-CoV-2 wild type after dose 3, and that third line, as you can see highlighted in red, were noted at 98.5%. If we look at seroresponses in participants with and without evidence of infection, they too also had high seroresponse rates. It was 99.1%, but it's not written on this slide. Next slide, please. I'd like to shift and talk about the supportive analysis that was conducted now using those participants from our 3-dose set to assess responses to Omicron in the first row and wild type noted in the second row, who had samples at both time points. If we look at the first row for Omicron, you can see that there were robust neutralizing titers elicited after dose 3, which was 614.4, compared to dose 2, which was 27.6, for a geometric mean ratio of 22. As we looked at wild type, or the reference strain on the bottom, we also saw similarly improved geometric mean titers after dose 3 compared to dose 2, with a geometric mean ratio of 5. As we go into the last slide, in the evaluable population, as we look at those now with and without evidence of infection in this supportive analysis, you again see increased geometric mean titers noted 1 month after the 3rd dose. They were higher than the previous 992.7 compared to dose 2, which was 27.3, for a geometric mean ratio of 36. And similarly, we saw an increase in our reference strain, or the wild type, with a geometric mean ratio of 6. With that, I'd like to come to my immunogenicity conclusions. If you go to the next slide. So thank you. In participants with and without evidence of prior infection, administration of a booster 3rd dose of BNT162b2, 10 micrograms, elicited robust neutralization titers against SARS-CoV-2 wild type. In addition, a booster 3rd dose of BNT162b2, 10 micrograms, elicited neutralizing titers against SARS-CoV-2 Omicron in participants with and without evidence of infection. Overall, the immune response associated with the booster 3rd dose of BNT162b2, 10 micrograms, given at least 6 months after the 2nd dose, is expected to confer protection against COVID-19, including that due to Omicron. And with that, that concludes my presentation, and I welcome any questions.
Thank you very much. This presentation is now open for questions. Dr. Lehr.
Thank you for your presentation. Could you go back one slide, please? I'm trying to parse out the 2 sentences and what the difference is between the first dot and the second dot, because those sentences look very similar to me.
No, of course. So maybe if it's easier, I can perhaps take you back to the slides and explain the difference. So if we go back to slide, let me see, 18. Perfect. So this was the initial analysis that we did with our validated SARS-CoV-2 assay that looked at the wild type. So for this assay, what I was referring to in the bullet was this data that looks at our SARS-CoV-2 wild type. And as you go, this was the original analysis, and then we did another supportive analysis using a different assay to look at Omicron to show again, if you go, 2 slides forward, that is the supportive analysis that looks at Omicron. So that's what those 2 bullets represent. I clarified.
Thank you. That clarifies it for me.
Okay.
Dr. Dudgeon.
Thank you. Thank you for this presentation.
My question is just about the dosing interval between the second dose and the booster. I believe it was 8 to 9 months in this study, and I'm wondering if you can comment on the potential implications of that dosing interval, or your findings related to that dosing interval, should a different dosing interval be recommended.
Sure, I'm happy to. So if I'd like to just explain the reason for the dosing interval first, and just to go back to the slide 3, perhaps, if we could, that shows the timeline. So in terms of when the dose 3 began and was implemented, it was anywhere between the 5 to 9 months in the existing participants. And we know that when there's a wider interval, that we do expect higher geometric mean titers or neutralizing titers. In terms of the recommendations, again, we did see that participants did have, in the immunogenicity group, they were dosed between 7 and 9 months as well. I don't anticipate any differences in those geometric mean titers given the interval between dose 2 and dose 3. But I'd welcome Dr. Bill Gruber to add any additional comments.
Yes, thanks, Char. This is Bill Gruber. I head the Vaccine Clinical Research and Development Group for Pfizer. And Char has said it exactly right. I mean, we know in terms of other populations there may be some difference, but we have seen reliably protection even with a shorter interval in terms of booster dose given after the first 2 doses. So the expectation would be that all the antibody responses might be a little bit lower, that they still should be providing additional protection, much as you've seen in other populations that were described this morning from the CDC. Particularly, I think, informative is the adolescent population, where you've got some experience now with a 3rd dose.
Thank you. Dr. Palin?
Yes. Thank you for this great presentation. One of the things I particularly appreciated was that we separated out those who were vaccinated who had no evidence of infection from those that had evidence of infection. And I was wondering if a similar analysis was done on reactogenicity. Thank you.
No, thank you for that question. For our safety population, we did not do a separate analysis looking at those with prior infection, but as noted at baseline, 5.5% did have a positive SARS-CoV-2. And what I'd like to take you back to is actually, we know from the data that we presented in our 2-dose series that there was actually no differences between those who did have a positive SARS-CoV-2 and those that were negative. And we can bring up that slide if it's useful. I do have it in backup. It's slide 41, if that's helpful, just to lay eyes on this to show that we, in a large 2-dose series, we didn't see a difference. And as the dose 3, we've seen it's comparable to our dose 2, don't anticipate any additional differences.
You might show also, this is Bill Gruber again, you might just also show the systemic reactions, which I think is the slide after this one, if I'm remembering this right.
Correct. Thank you so much, Bill.
And maybe I'll just comment, as Char said, we haven't analyzed this specifically after the 3rd dose, and those that were seropositive or had other evidence based on PCR of having had approximate COVID-19 infection. But I think you can gain some reassurance given that the expectation would be that, if anything, a proportion might be higher that had been infected, prior, approximate to dosing, and yet the reactogenicity is basically the same or less. So I think that provides some confidence that we're not seeing an augmentation in terms of reactions, either in the individuals that have had no experience with COVID-19 or those that have.
And then I can just add also, that'll continue to gain confidence, that we did look at our immunogenicity sets, as we did have that data for those participants at dose 3, whether they were SARS-CoV-2 previously exposed. And if we looked at those calculations, it was roughly a quarter of them. So we didn't see that translated into our reactogenicity results.
Thank you. I have one quick question, hopefully. If you go to slide 18, may I just ask, do you have a similar slide for participants with evidence of prior infection? I'm curious about what their GMTs look like before dose 3.
So I do not have just with. I do have with and without, but I am happy to show you the actual data table that supports it if we go to slide 28. So this is set up obviously in a tabular format with a 3-dose set and the 2-dose set, and then you see the totals all the way at the right. And you can see here that excuse me, I took you to the wrong slide, apologies. Slide 30. There we go. If we now look at this slide, this is the slide that will actually show you the geometric mean titers that I was referencing in the actual verbal discussion. You can see that post-dose 3, the GMT is over 3,000 compared to 1 month post-dose 2, which was 1,200. This geometric mean ratio was higher than what we saw in those without evidence of infection. So we saw that they did contribute additional neutralizing titers at the 1 month post-dose 3 time point. That answers your question.
It does. I think just looking at the numbers, if you can, gestalt from it, it's still lower than I would have anticipated pre-vaccination, pre-dose 3. I would have anticipated it to be higher, but it's not as high as I would have thought after an infection, perhaps because these are asymptomatic infections. Christy Moling-Gessel, would you like to go ahead and ask a question?
Yes, thank you so much, and thank you for this presentation. I would just be interested in hearing you speak a little bit to the methods of these 401. It looked like, if I'm recalling correctly, there's about 4,500 in the data set initially, and then 401 that completed the 3rd booster dose. Was that due to just a limited subset of invitees based on powering for sample size to look at this additional booster set, or do you have any qualitative or quantitative data to those that decided not to continue for the 3rd dose, on who those participants may be?
Sure, so happy to speak about that. So if we go back to slide 3, what I just wanted to take you back to is that we initiated the first booster dose on January 31st, and we were looking to have all those participants complete their 1 month post-dose, their vaccination by February 22nd, excuse me. So it was that interval duration time from when the sites were able to actually bring in the participants and get them dosed. So that was at the very beginning of when all the participants were included. So they were actually reflective of the initial group. I can say to you that the vast majority of all participants have now completed their dose 3. It was the interval of the data cut in order to provide the necessary safety database. And the safety database that we provided is similar to what was provided to the 1 month post-dose 3 booster for the 18 to 55-year-olds.
Thank you.
Thank you. Are there any other questions? I have one more clarifying question. When you document prior infection, do you document that with PCR at the time of their visits that happens to occur, or do you do nucleocapsid antibody as well?
We do both.
Okay, thank you. All right, I see no further hands raised. Last call. Thank you very much for your presentation, Dr. Sabherwal. We'll move on to Dr. Sarah Oliver, who will provide updates to the ETR framework on COVID-19 vaccine booster doses in children 5 to 11 years of age. So we'll just wait for Dr. Oliver's slides to come up, and we'll transition to that section. Thank you.
Great, thank you so much. Next slide. So today we'll be discussing this policy question: should individuals 5 through 11 years of age receive a Pfizer-BioNTech COVID-19 vaccine booster dose at least 5 months after completion of the primary series based on the balance of benefits and risks? Next slide. You guys are well familiar at this point with the adapted ETR framework we've used for booster doses of COVID-19 vaccines. Next slide. So we'll start with the public health problem. Next slide. We'll review available evidence, focusing on recent epi of the COVID-19 pandemic during the Omicron variant predominance. We'll cover COVID incidence and burden estimates, COVID-associated hospitalization rates and mortality, updates to MISC, a review of post-COVID conditions, and other impacts of COVID, such as missed school. And finally, COVID-19 vaccine doses administered in this age group. Next slide. This graph shows the overall trends and number of COVID-19 cases in the United States. As of May 16th, there were more than 82 million total recorded cases of COVID-19. After reaching a recent nadir where the 7-day average of new daily cases was around 25 to 30,000, the current 7-day average of cases is around 95 to 99,000 cases per day. Next slide. Now focusing in on the pediatric population, this figure shows the weekly rate of COVID-19 cases per 100,000 population among children 0 to 17 years by age group, with children ages 5 through 11 years shown in the bolded red line. COVID cases among the pediatric population, including children aged 5 through 11, were much higher during the Omicron predominant period compared to any previous time during the pandemic. Next slide. Not all COVID cases are captured using traditional disease surveillance methods in the prior two figures, because some cases are asymptomatic, not diagnosed, or not reported. Tracking the proportion of the population with SARS-CoV-2 antibodies, or seroprevalence, can improve the understanding of population-level incidence of COVID-19. This figure shows the seroprevalence of infection-induced SARS-CoV-2 antibodies from the National Commercial Lab Seroprevalence Study from September 2021 through February 2022 by age group. Seroprevalence in all age groups increased substantially during the Omicron wave. And since October of 2021, children 5 through 11 years, which is shown in gold, have had the highest seroprevalence of all age groups. And by February of 2022, it was estimated that 77% of children 5 through 11 years have had serologic evidence of prior SARS-CoV-2 infection. Next slide. We can also look at rates of COVID-19 cases by vaccination status, as this figure shows the incidence of positive COVID tests per 100,000 population among children ages 5 through 11 years in 27 U.S. jurisdictions from December 11th of 2021 through March 19th of 2022. During the Omicron predominant period, COVID incidence rates among unvaccinated children ages 5 through 11, shown in the dashed line, were 1.3 times higher than rates in vaccinated children, shown in the solid line. However, it is important to note that there are crude rates for infection, and possible differences in testing, immunity from prior infection, or prevention behaviors by age and vaccination status haven't been accounted for here. Next slide. Moving on to hospitalizations, this figure shows COVID-19 associated hospitalization rates per 100,000. In gray, we see the overall hospitalization rate for all ages, and in blue, we see the hospitalization rate among children 5 through 11 years. While hospitalization rates for children in this age group remained low when compared to the overall hospitalization rate, there is an increase in hospitalizations during the Omicron period. Next slide. Then we can also examine hospitalization rates by vaccination status. Here we see the monthly COVID-19 associated hospitalization rates in children ages 5 through 11 by vaccination status from January to March of 2022. During the Omicron predominant period, COVID-19 associated hospitalization rates among unvaccinated children 5 through 11, shown in the dashed orange line, were twice as high as rates among vaccinated children, shown in the solid blue line. Next slide. A recent COVIDnet MMWR described COVID-associated hospitalizations in children ages 5 through 11 throughout the pandemic. Again, focusing on this Omicron predominant period, during which COVID-19 vaccination was recommended in this age group, 87% of hospitalized children were unvaccinated. Among unvaccinated hospitalized children, over half were Black or Hispanic. 1/3 of hospitalized children had no underlying medical conditions, and 27% required ICU admission. No significant differences were found for severe outcomes by vaccination status, which is likely due to low numbers of hospitalized vaccinated children. However, there were no vaccinated children who required higher level oxygen support. Next slide. We can also look at hospitalization rates by vaccination status among adolescents, as they are already recommended to receive a booster dose 5 months after receipt of their primary series. This figure shows monthly hospitalization rates in adolescents 12 through 17 by vaccination status from, again, January to March of 2022. Rates among adolescents who are unvaccinated are shown in the dashed orange line. Adolescents vaccinated with the primary series are shown in the lighter blue line, and adolescents vaccinated with the primary series plus booster are shown in the dark blue line. During March, the monthly COVID-associated hospitalization rates among unvaccinated adolescents aged 12 to 17 were 2.5 times higher compared to rates among adolescents vaccinated with the primary series plus booster. Next slide. Now moving to mortality due to COVID-19. This figure shows the number of COVID-19 deaths by single-year age group from January 1st of 2020 to April 30th of 2022. Among children ages 5 through 11 years, there were 189 COVID-19 related deaths, which made up 2.5% of all deaths among children in this age group. Next slide. Here we see the leading causes of death among children ages 5 through 11 years in 2020, and COVID-19 was the 11th leading cause of death among children in this age group. Next slide. Multisystem inflammatory syndrome in children, or MIS-C, is a severe hyperinflammatory syndrome occurring 2 to 6 weeks after acute SARS-CoV-2 infection, resulting in a wide range of manifestations and complications. 60 to 70% of patients with MIS-C are admitted to intensive care, and 1 to 2% die. The incidence early in the COVID pandemic from April to June of 2020 was approximately 1 case of MIS-C per 3,000 SARS-CoV-2 infections in person 21 years and younger. We know incidence is the highest among minority children and adolescents, including non-Hispanic Black and Hispanic or Latino children or adolescents. Next slide. So here we see the daily MIS-C and COVID-19 cases reported to CDC, with MIS-C represented by the blue line and corresponding to the y-axis on the left, and COVID-19 cases represented by the dashed black line and to the y-axis on the right. In total during the pandemic, 8,210 cases of MIS-C and 68 deaths have been reported among children of all ages. As you can see, reports of MIS-C typically follow increases in COVID cases. However, following the Omicron surge, reports of MIS-C did not increase to the same level as had occurred during prior waves of COVID cases. Next slide. Then this figure shows the weekly MIS-C case counts by age group during the same time frame. Children ages 5 through 11, which are shown in orange, are the most common age group affected by MIS-C. During the pandemic, among children 5 through 11 years of age, there have been 3,800 MIS-C cases and 16 deaths. Next slide. So next, to discuss post-COVID conditions. We know post-COVID conditions occur in children, although it may be less common in children than in adults. A national survey in the UK found 7 to 8% of children with COVID-19 reported continued symptoms 12 weeks or more after. Post-COVID conditions can appear after mild to severe infections and even after MIS-C. The most common symptoms include fatigue, headache, insomnia, trouble concentrating, muscle and joint pain, and cough. These conditions also have an impact on quality of life, including limitations of physical activity, feeling distressed about symptoms, mental health challenges, and decreased school attendance or participation. Next slide. So this prospective cohort study examined post-COVID conditions among children who'd been previously hospitalized for COVID between April and August of 2020, and highlights the risk factors for post-COVID conditions and symptoms experienced among these children. The figure on the left report risk factors for post-COVID conditions. Compared to the youngest children, children 6 through 11 years and 12 to 18 years have a higher risk of post-COVID conditions. Children with a history of allergic diseases are more likely to report post-COVID conditions compared to those without a history of allergic diseases. Then the figure on the right highlights that many of the common symptoms experienced by adults are also experienced by children, with fatigue as the green line on the graph being the most common, followed by sleep problems. And similar to adults, symptoms decrease over time. Next slide. Non-hospitalized children who experience milder acute infection also report post-COVID conditions. These are results from a survey of children in the UK. The percent reporting a positive SARS-CoV-2 test ranged from 20% in 5 through 11-year-olds to 30% in 16 to 11 to 16-year-olds. 2 to 7% had ongoing symptoms at 12 weeks. The symptoms increased among older age groups, and up to 5% had symptoms that impacted daily activities of daily living. Next slide. Then children with MIS-C appear to have a higher risk of ongoing symptoms following MIS-C as well. Continued difficulties have been reported by 35% of children and 21% of parents at 6 months. In these figures from a 6-month follow-up study of patients with MIS-C illustrate the number of systems impacted. In the figure, each radial segment, so the lines going out from the center, are shown is a specific patient, with children in white and adolescents in gray. The affected symptoms are shown in various colors and include systemic inflammation, gastrointestinal, renal, cardiac, or neurologic. Over time, the wheels become less colorful, indicating fewer symptoms involved, but the number of symptoms affected at baseline, which is the circle on the left, is greater than those affected at 6 weeks in the middle circle or by 6 months in the right circle. But a number of children and adolescents still have symptoms at 6 months. The most common systems involved are neurologic, which are shown in that teal color. Next slide. Then most studies that look at post-COVID conditions occurring after vaccine breakthrough have focused on adults, but there have been 2 to date that have included adolescents. These found that persons who were previously vaccinated were less likely to have symptoms between 12 and 20 weeks after infection compared to persons who were unvaccinated. And persons who were previously vaccinated had a lower occurrence of post-COVID conditions after infection compared to persons who were unvaccinated. Next slide. Then we know another important impact of COVID-19 on children is disruption in in-person learning in school. This figure shows COVID-19 related K-12 school disruptions by week, with disruptions defined as school moving away from regular in-person instruction, caused in some way by the pandemic. COVID-19 related school disruptions continued through the 2021-2022 school year, specifically during the Omicron surge. Next slide. then overall we know that there are other indirect impacts on the COVID-19 pandemic in children, including worsening of mental or emotional health, widening of existing education gaps, decreased physical activity and increased body mass index, decreased healthcare utilization, decreased routine immunization, and an increase in adverse childhood experiences. Next slide. So now transitioning to COVID-19 vaccine coverage, which are shown in these figures by age group. On the left, we see coverage with at least one vaccine dose, and on the right is coverage for those who are fully vaccinated. In both figures, you can see that coverage is among the highest in the oldest age group and decreases among younger ages. Coverage is lowest among children ages 5 through 11 years, which are shown in the dashed gold lines. So 35.4% had received at least one dose, and 28.8% were fully vaccinated. Next slide. Then if we look at COVID-19 vaccination coverage within the 5 through 11 year age group, you can see that coverage decreases with decreasing age, and the highest two-dose coverage at 32% is among 10 and 11-year-olds, with the lowest at only 25% among 5-year-olds. Next slide. In summary, children 5 through 11 years of age are at risk for severe illness from COVID-19. There have been over 4.8 million reported cases and over 15,000 hospitalizations in this age group to date. In 2020, COVID-19 was a leading cause of death in children ages 5 through 11 years. Children vaccinated against COVID-19 have better outcomes, particularly against severe illness, but only 28% of children ages 5 through 11 have completed their primary series. Next slide. So moving to benefits and harms. Next slide. For a review of the available evidence, for benefits we'll present immunogenicity of the third dose. For harms, we'll focus on adverse events and reactogenicity from the clinical trial. Then we'll also discuss other considerations, including seroprevalence, myocarditis, and estimates of a benefit-risk analysis. Next slide. As we've just heard, the immunogenicity data come from an open-label continuation of the Pfizer phase 2-3 randomized controlled trial, and among children 5 through 11 in the U.S., the data consists of 67 children who received a 10 microgram booster dose and 67 participants randomly selected from the previously analyzed two-dose population. Immunogenicity analyses were based on immune responses at each time point with a descriptive comparison of the immune response at 1 month post-dose 3 compared to the immune response at 1 month post-dose 2. All participants who received dose 3 got the booster dose at 7 months or more after dose 2, most commonly around 8 to 9 months post-dose 2. Next slide. Again, 67 participants in the 2-dose set and 67 in the 3-dose set. Among the 3-dose set, there were also 29 that had a 1 month post-dose 2 analysis. Next slide. In this slide, we see the geometric mean titers for the 3-dose and 2-dose sets at different sampling time points. You can see at 1 month post-dose 2, the GMTs increased sharply initially, but decreased substantially by the sampling point prior to dose 3. Then at 1 month post-dose 3, the GMTs are considerably higher than what they were following dose 2. Next slide. Then on this slide, we're specifically looking at the geometric mean ratio, comparing the geometric mean titers from 1 month after the 3rd dose to 1 month after the 2nd dose. Comparing these two groups, the GMR is 2.17, meaning the GMTs after the 3rd dose were double what was seen after the 2nd dose. Next slide. Safety data also come from an open-label continuation of Pfizer's phase 2-3 randomized controlled trial, including 401 participants 5 through 11 who received the 10 microgram booster dose. Of those, 5.5% were baseline SARS-CoV-2 positive. Data are through March 22nd and include a median of 1.3 months follow-up. Next slide. There were no serious adverse events reported among trial participants. There were no deaths, no cases of anaphylaxis, and no cases of myocarditis. Cases of lymphadenopathy, including a palpable lymph node axillary mass, were reported by 10, or 2.5% of participants. This frequency of lymphadenopathy after dose 3 in children 5 through 11 is higher than what was observed after dose 2 in this age group, but is almost half what was observed in adults after a booster dose. All cases of lymphadenopathy reported after dose 3 were mild. Most were identified as occurring in axillary or cervical nodes, had an onset within 2 days after the booster dose, and were reported as resolved within roughly 1 week after onset. Next slide. Here are the definitions for local and systemic reactogenicity at grade 3 or higher. I won't review these in detail, but they're here for reference. A typical way to think about this is grade 3 or higher represents an interference in daily activities. Next slide. In this figure, we can see that injection site pain is the most common reported reaction after a third dose, with roughly 75% of participants reporting this symptom. 16% reported swelling or redness at the injection site after dose 3, and the local reactions were comparable to reactions following doses 1 and 2. Next slide. For systemic reactions, fatigue was the most commonly reported among children 5 through 11 years after every dose. 46% of participants reported this after the third dose, which was similar to what was seen after the second dose. Another commonly reported symptom was headache or muscle pain. Antipyretic or pain medicine use was used by roughly 1/3 of participants after a third dose, and this was slightly more frequently than seen after the first or second dose. Next slide. Again, severe local reactions, those that prevented activities of daily living, were reported infrequently in less than 1% of participants after each dose. There were 2 events of injection site pain after dose 3 and 1 severe event of injection site redness after dose 3. There were no grade 4 local reactions after dose 3. Severe systemic reactions included 7 events of severe fatigue, 3 events of severe headache, and 1 event of severe chills or severe diarrhea. There were no grade 4 events after dose 3. Next slide. So in summary, while we don't have estimates of efficacy after a booster dose in this population, we do know that a third dose of the Pfizer vaccine elicited robust neutralizing antibody titers. The GMTs observed 1 month after the third dose were substantially higher than the GMTs observed prior to the booster dose. On the harm side, there were no serious adverse events or cases of anaphylaxis or myocarditis. Systemic and local reactogenicity after the third dose were overall similar to reactogenicity after the second dose. Most events were mild and resolved within 1 to 2 days. Next slide. Turning now briefly to touch on seropositivity. In the clinical trials for children 5 through 11 years, 5.5% of children in the booster safety population were baseline SARS-CoV-2 positive. And as a reminder, almost 9% of the children in the primary series trial were baseline SARS-CoV-2 positive. According to recent studies in the US we just discussed, approximately 77% of children 5 through 11 have evidence of prior SARS-CoV-2 infection. However, seropositivity should not be interpreted as protection from future infection. We know that prior infection can result in protection against reinfection for a time period, but it's not 100% and likely decreases over time. Next slide. The Omicron wave surges of pediatric hospitalizations occurred even in the setting of this high seroprevalence, suggesting that this alone is not sufficient to provide broad population-level protection. There were no concerns identified in safety surveillance with vaccinated of seropositive individuals. And a recent update to the clinical considerations states that people who've recently had SARS-CoV-2 infection may consider delaying their COVID-19 vaccine booster by 3 months from symptom onset or positive test. This is because we do know that an increased time between infection and vaccination may result in an improved immune response to vaccination, and there is a low risk of reinfection in the initial weeks to months following infection. Next slide. Then regarding vaccine safety, we can draw on what we know from booster doses in other ages as well. After 93 million mRNA booster vaccinations in the US in individuals 12 and over, we know that local and systemic reactogenicity appear at similar frequencies or slightly less for that first mRNA booster compared to dose 2 of the primary series. The data were presented in detail at our last ACIP meeting in mid-April, so I won't go through them in detail, but in summary, for myocarditis, the findings were consistent with those observed with the primary series, where the risk was highest in younger males, but the overall risk is lower following the first booster dose compared to dose 2 of the primary series. An increased risk of pericarditis was also detected after a first booster administration, but is less common, more evenly distributed between males and females, and more evenly distributed across age groups. Next slide. Then what we know specifically in the 5 through 11 population, identified rates of myocarditis after the primary series are lower than what we see in those 12 to 17 years. And again, as just mentioned, as we know from other age groups, rates of myocarditis are lower after booster than the second dose in the primary series. Next slide. So to consider the benefits and risks of the primary series in children 5 through 11, we estimated predicted hospitalizations prevented versus myocarditis cases per million second doses during the Omicron surge. In the 3 months after primary series recommendations in this age group, we estimate that per 1 million second doses, 133 hospitalizations, 30 ICU admissions, and 0 to 1 deaths were prevented, while 1 to 2 myocarditis cases were expected. So if we zoom this out to the whole population, among the 7.5 million fully vaccinated children, we estimate that approximately 1,000 hospitalizations may have been prevented during the Omicron surge through receipt of the primary series. Next slide. Then this slide was also shown at the last ACIP meeting with VE for a variety of outcomes for 2 doses shown in green and 3 doses shown in pink. And you can see here that receipt of a booster dose increases protection across every outcome listed. Next slide. So in summary, waning of antibody levels was seen after completion of a 2-dose primary series, and booster doses achieved antibody levels higher than what was seen after the primary series. Symptoms reported after a booster dose were similar to what was reported after the primary series. Rates of myocarditis after primary series in children 5 through 11 are lower than what is seen in adolescents, and rates after a booster dose are likely even lower. Then, as we've already discussed earlier today, in the adolescent male population, where the risk of vaccine-associated myocarditis is the highest, the risk of cardiac complications after COVID infection was still 2 to 6 times higher than vaccine-associated myocarditis. Receipt of the primary series of COVID vaccines remains important and continues to provide protection against severe COVID-19 outcomes. But based on information from other age groups, providing a booster dose can increase protection against both COVID-19 infection and severe disease. Next slide. So moving to values and acceptability, next slide. Since little was known about U.S. parental attitudes, beliefs, and intentions surrounding COVID vaccines for children prior to their introduction, an online cross-sectional nationally representative survey of U.S. parents and guardians of children less than 18 was conducted using the Ipsos Knowledge Panel. The goals and objectives of the project were to assess parental attitudes and beliefs about SARS-CoV-2 related disease and vaccines, gauge parents' acceptance of COVID vaccines for children, characterize parents who reported willingness to vaccinate their child against COVID, and evaluate factors that may influence parental willingness to vaccinate. Next slide. So this slide looks at predictors of respondents' willingness to have children receive a COVID vaccine from a longitudinal sample of respondents who completed the first wave of the survey conducted in February of 2021. As illustrated, parent or guardian's willingness to vaccinate themselves was the most important predictor of a COVID vaccine acceptance for their children, whereas perceived barriers to COVID vaccine was a negative predictor. Next slide. So conclusions from Wave 1, before data on pediatric vaccines were widely available and before vaccine rollout to the younger age group began, 66% of parents intended to vaccinate their children. Those who were very or somewhat unlikely to vaccinate their children more frequently reported that school or travel requirements would make them more likely to vaccinate. And those who were somewhat likely to vaccinate their children reported that a healthcare provider recommendation, school requirements, or peer influence would make them more likely to vaccinate. And all groups reported that serious or severe side effects would make them less likely to vaccinate. Next slide. Then a longitudinal sample with a second wave was fielded from October to November of 2021. The primary outcomes were parental vaccine acceptance, broken down by age of the child, Questions again were centered around beliefs about and experiences of SARS-CoV-2 related disease and beliefs about COVID vaccine. Questions were also included regarding influence on COVID-19 vaccine decision-making, broken down by age of the child as well. Next slide. This slide looks at parental characteristics and household composition. Roughly 60% of parents had more than one child in the household. Average age of parents was 40, and the education level was a bachelor's degree or higher. Moreover, 86% of parents were accepting of routine childhood vaccinations, and 71% were vaccinated against COVID themselves. Next slide. So taking a look at parental attitudes around COVID vaccines, roughly 60% of respondents strongly agreed that the child's healthcare provider is a reliable and trustworthy source of information around COVID vaccines. Around half said they're concerned about possible serious or rare side effects, and more than a quarter said that vaccines may not work or are not needed for children. Next slide. So now taking a look at the likelihood and expected timing of vaccinating children. Compared to 70% of adolescents 12 to 17, the likelihood of vaccination among children 5 through 11 was 54%, with 36% very likely and 18% somewhat likely. Approximately 41% of parents of children 5 through 11 wanted to wait until other children had been vaccinated. Next slide. And giving an overview of net predictors for vaccine acceptance and factors influencing a parent's decision to get their child vaccinated. The belief in the benefits of COVID vaccine and acceptance of routine childhood vaccines were the most important predictors of COVID vaccine acceptance for their child. Positive predictors also included perception that pediatric COVID-19 related disease was severe, as well as Hispanic ethnicity and parental COVID-19 vaccination. Additionally, the desire to protect their child from COVID and protect their children against new variants were the primary determining factors towards the parents' decision to get their child vaccinated. Next slide. In summary, about half of parents are worried about rare and serious side effects of the COVID vaccines, but many are also worried about how new variants will affect their children. Moreover, we can expect to see a slow COVID vaccine uptake in the 5 through 11 age group, as around 41% of parents plans to wait and see, but ultimately around 60% of parents of children 5 through 11 intended to vaccinate their children at some point. And as we continue to emphasize, most parents trust their children's healthcare provider as a source of information around COVID-19 vaccines. Next slide. Now for feasibility and implementation. This slide looks at the percent of children who received at least one dose of the COVID pediatric vaccine by jurisdiction. Again, while 35% of children 5 through 11 reportedly received at least one dose of the vaccine, this clearly varied by state. Next slide. Now, taking a look at the weekly numbers of COVID vaccine doses administered to children 5 through 11, we can see that although nearly 10 million first doses had been administered since November 3rd, many of those doses were given in the first several weeks after authorization, and very few primary series are being initiated now. Next slide. This table shows the parent-reported place of COVID-19 vaccination among children 5 through 11 years from November 2021 to February of 2022, based on results from the National Immunization Survey Child COVID-19 module. Medical place and pharmacy were the highest reported places for COVID-19 vaccination among children 5 through 11. Next slide. So to maximize pediatric vaccination opportunities, federal, state, local, and pharmacy partners have developed a robust network of providers trained to serve pediatric populations and best manage the vaccine given product and supply considerations, with particular focus on ensuring access in the most underserved communities at risk for COVID-19 related illness and death. Approximately 4 weeks after the pediatric vaccination program was launched, over 38,000 providers were enrolled, and 92% of children 5 through 11 lived within 5 miles of an active provider. Next slide. Among nearly 38,000 vaccines for children, or VFC providers, approximately 2/3 are enrolled to administer COVID vaccines, and roughly 1/3 have ever administered a COVID vaccine to a child age 5 through 11. Some barriers to enrollment or participation in the program were due to the availability of vaccines available elsewhere in the community, concerns about vaccine waste, low demand or parental hesitancy, limited staff resource or storage space, and reporting burden. Next slide. So in an effort to maintain or strengthen this provider network, CDC has initiated multiple activities, which consist of creating jurisdiction-specific maps of providers to assist jurisdictions with identifying gaps, encouraging jurisdictions to partner with local AAP or AFP chapters for support, continuing to emphasize the importance of the VFC provider participation, addressing identified enrollment or participation barriers, and continuing to support the Federal Retail Pharmacy Program Partnership. Next slide. Then overall, we see similar patterns for booster dose uptake by age, where older populations have the highest coverage. Note that among adolescents, only 25% of fully vaccinated adolescents have received a booster dose to date. Next slide. So in summary, again, 35% of children 5 through 11 have received at least one dose of this vaccine, and nearly 10 million doses have been administered since November 3rd. Medical facilities and pharmacies were the highest reported place of vaccination among children 5 through 11, and efforts to strengthen the provider network and mitigate barriers to provider participation is crucial to improving pediatric COVID vaccine coverage. However, in spite of efforts to encourage vaccination and close any provider gaps, booster dose coverage remains low among adolescent and young adult populations. Next slide. And finally, for equity, next slide. This figure shows the weekly rates for completed primary series for children 5 through 11 by race and ethnicity. Here, again, we can see the initial peak following EUA, followed by a small peak in early January, potentially due to the concerns of the Omicron surge. Next slide. And here we see percent of children with a completed primary series by race and ethnicity. 57% of non-Hispanic Asian, 35% of American Indian and Alaska Native children have completed their primary series, while coverage is only 17% among non-Hispanic Black children. Next slide. This figure shows the percent of children 5 through 11 with at least one dose of the COVID vaccine by Social Vulnerability Index of the county of residence from November through April 27th. As illustrated, the highest vaccination rates were among those residing in low SVI counties at 37%, where the lowest rates were among those residing in high SVI counties at 31%. Then as a reminder, CDC's SVI is the social index identifies socially vulnerable populations, especially at risk during a public health emergency because of factors like socioeconomic status, household composition, minority status, or household type or transportation. Next slide. Then this figure shows the percent of children 5 through 11 with at least one dose by urban or rural status of the county of residence. As illustrated, there's a relatively large gap in the percentage of children with at least one dose between those who reside in large urban areas at 40% and rural areas at 14%. Next slide. We see a similar gap when we look at parental intent for children 5 through 11. We see that the lowest intent, shown in the darker shades of blue, is among uninsured individuals on the bottom right, and a sharp difference for those who reside in rural areas. Next slide. Taking a further look at disparities in COVID vaccine coverage between urban and rural counties across the U.S., compared with recent estimates, the urban-rural disparities among those now eligible for vaccination have increased more than twofold through January of 2022, despite increased availability and access to COVID-19 vaccine. The disparities were seen across all age groups. However, the largest differences were seen in the pediatric populations. Next slide. There were multiple factors that may have contributed to increasing disparities in this vaccination coverage in urban and rural counties. Parents in rural communities were approximately twice as likely to state that their child definitely would not get a COVID vaccine compared to those in urban communities. Notably, again, 76% of parents in rural communities indicated that the trusted source of vaccination for their children is a healthcare provider. However, nearly 40% of rural parents reported that their child's pediatrician did not recommend a COVID vaccine. compared with only 8% of parents in urban communities. Again, healthcare providers remain a trusted source of information for parents. And vaccine recommendations from a healthcare provider is a strong predictor of COVID-19 vaccination. The reported disparity between urban and rural pediatricians highlights the importance of partnering with healthcare providers and provider organizations to reduce vaccine hesitancy and increase vaccination coverage. Next slide. Overall methods to address vaccine equity consist of developing and disseminating culturally and linguistically appropriate messaging through trusted channels identified by partners working closely in the communities of interest, implementing content for parents or caregivers, promoting web pages for clinicians and families focused on children's, including those with disabilities and special healthcare needs, supporting rural vaccine communication and education partnerships, and even developing a rural addendum to the COVID vaccine field guide. Next slide. So in summary, there are noted disparities in vaccination coverage and parental intent for children 5 through 11 years by race and ethnicity, income, and geographic location. Addressing barriers to vaccination in rural areas is critical to achieving vaccine equity, reducing disparities, and decreasing COVID-19 related illness and death in the United States. Additional outreach is critical, especially in high SVI areas and rural areas, to improve vaccine confidence and increase coverage rates among children. And disseminating culturally and linguistically appropriate message through trusted channels is important to reaching parents and caregivers who reside in areas with low vaccination coverage among children. Next slide. So in summary, next slide. A version of this slide was shown in early November when ACIP met to discuss the initial primary series for this age group. From the beginning of the pandemic until that time, among children 5 through 11 years of age, there had been 1.9 million cases, 8,300 hospitalizations, and over 3,000 MIS-C cases and 94 deaths. Next slide. Since authorization of COVID vaccines in early November, we've experienced the Omicron surge. Throughout that time, there were 2.9 million cases, 6,700 hospitalizations, over 700 MIS-C cases, and 95 deaths. Next slide. We know among those cases, around 90% of hospitalized cases and over 90% of MIS-C cases were unvaccinated. Just wanting to highlight the continued burden of vaccine-preventable disease in this age group. Next slide. As we've highlighted throughout this presentation, the receipt of a primary series provides protection against COVID-19, especially against severe disease. Myocarditis after COVID vaccines in children 5 through 11 is rare. Only 29% of children 5 through 11 are fully vaccinated with the primary series. As was starkly highlighted in the Omicron surge, future surges will continue to impact children, with unvaccinated children remaining at higher risk of severe outcomes. Overall, the benefits of COVID vaccines continue to outweigh the risks. As we continue to see, regardless of what age group is highlighted, receipt of the COVID vaccine primary series continues to be critically important for the prevention of severe COVID-19 morbidity and mortality. Next slide. Then overall, COVID-19 vaccine booster doses COVID-19 vaccine booster doses have been shown to increase protection against all outcomes in those 12 and over. We've seen waning of protection over time after 2 doses are noted for ages 12 and over. There's both limited time and numbers to sufficiently detect waning in children 5 through 11, but we can apply lessons learned from other age groups. In addition, for each age, myocarditis rates after booster doses of COVID vaccines are lower than given what we see after a second dose in a primary series. Given what we know from other age groups, the totality of the data reviewed by the work group over the last several weeks and discussed today, it's likely that children ages 5 through 11 would benefit from a COVID-19 vaccine booster dose. After a thorough review of the data, the work group discussed vaccine policy where children 5 through 11 may receive or should receive a COVID vaccine booster dose. Next slide. So this slide highlights the pros and cons for both what we've called the standard recommendation, or the should receive, in the top row, and the recommendation based on individual assessment of benefit risk, or the may receive recommendation. Thinking through the should receive recommendations, we know that these recommendations are simple to communicate. In addition, it's consistent with booster recommendations in other age groups. And as we've highlighted, it's likely that all children will benefit from 3 doses of an mRNA COVID-19 vaccine. However, highlighting that there were limited numbers of children 5 through 11 who received a booster dose in the clinical trial. In addition, while there isn't uncertainty about the benefits or safety of COVID boosters in this age group, there is some uncertainty around the ideal timing of receiving this booster dose, especially given uncertainty around the future of fall boosters and the fact that many children were recently infected during the Omicron surge. Then thinking through a May recommendation, the May recommendation reflects the uncertainty around fall epi and a possible future variant booster. It allows access for children who'd benefit most from the booster dose and allows flexibility to adjust to a stronger recommendation in the fall. However, we know that May recommendations can be complicated to communicate, which may be important in a population that already has lower coverage. In addition, it's not consistent with booster recommendations for the other age groups. And again, as mentioned, it's likely that all ages would benefit from this booster dose of an mRNA vaccine. Next slide. So to review, these are the current recommendations for COVID vaccine first booster. Those 12 and over recommended that they should receive a booster dose. Next slide. So if a recommendation for children ages 5 through 11 should receive, then this is what the new recommendations would look like. Next slide. And if it's recommended for children that they may receive a booster dose in the population, this is what this would look like. I will note that this type of recommendation would come with considerations for who should consider an earlier receipt of a booster dose, similar to what was discussed at the ACIP meeting on April 2nd for second boosters in older adults, but we'll note the added complexity of that. Next slide. Overall, the workgroup supported a recommendation that children 5 through 11 may receive a booster with flexibility to adjust to a stronger recommendation in the fall if epi warrants or newer vaccines are available. However, this was not unanimous, and both viewpoints were represented and discussed on the workgroup, highlighting the pros and cons that I just discussed. Next slide. Then before we move to the discussion and recommendations, I wanted to provide a few reminders. What you're discussing today is receiving a 3rd dose for children 5 through 11 who are not immunocompromised, but highlighting that immunocompromised children 5 through 11 are already recommended for a 3-dose primary series. So what you're discussing today is a booster dose, and that's the 4th dose overall for children who are moderate to severely immunocompromised. Next slide. Then just a reminder that the dose and formulation used in this age group is 10 micrograms in the Pfizer orange cap, which is the same used for the primary series in this age group. Next slide. So the policy question posed to ACIP is, should individuals aged 5 through 11 years receive a Pfizer COVID-19 vaccine booster dose at least 5 months after completion of the primary series, based on the totality of data reviewed today and the balance of benefits and risk? Next slide. So the question we'll pose to ACIP is, what does ACIP think about recommendations for booster doses in children 5 through 11, specifically thinking through a may recommendation or a should in this age group? However, before we toss it over, next slide, I just want to extend my deepest thanks to the team here at CDC who worked on the slides and provided data, as well as Dr. Adi Habersham for the survey and study data. So we can go back to the previous slide, and I'll turn it over to you, Dr. Lee. Thanks.
Thank you, Dr. Oliver. That was a phenomenal presentation, incredibly thorough as always. I want to thank you for all that you did to put this together in a very short time period. It was tremendous. I want to open up this presentation for discussion. Are there any questions and comments? Dr. Lair.
I would like to second the commendation for a spectacular presentation. I'd also like to say thank you for the extra information about MISC and long COVID. It's something I mentioned last time, and I really appreciate you putting that into this presentation. My specific question is, did the work group consider a may for the general population ages 5 to 11, but a should for the immunocompromised 5 to 11-year-olds? Thank you.
Thanks for that. It was briefly discussed on the work group. Overall, that's actually why I added the slide at the end to highlight that it's not, we're not talking about a third dose for everyone, that it's a third dose for the non-immunocompromised children and a fourth dose overall. The biggest concern, I think, is just the complexity. We've not done that for other age groups where we have a different strength of a recommendation for a subset of the population as that relates to that. But it was very briefly discussed on the work group. I don't know, Dr. Daly, if you want to comment any further on that.
No, I think you summarized it well, and it was discussed, but not discussed in more detail for the reasons that Dr. Oliver said, or not considered in more detail because it's not been an approach taken for other age groups. Thank you.
Thank you. Ms. McNally.
Thank you. Dr. Oliver, this really was a fantastic presentation, very clear, understandable, and obviously includes extremely important information. I'm wondering if the AAP is able to weigh in on this issue of boosters for 5 to 11. Thank you.
Thank you very much. Sorry for, I'm actually in transit to the airport, but I am the chair of the Committee on Infectious Diseases. We haven't actually had a policy statement. We were waiting for data to review at this meeting, but we have certainly been in favor, as you've heard, all of Dr. Oliver and other presentations about making sure that children are allowed to have the best access to vaccines possible. You see the inequities that we've already seen in this age group in particular. And so as an individual, I would, I do approve of the may or should. We'll see what the ACIP working group, the ACIP committee comes up with finally, but I do think having some access is going to be important, and I would also urge equity issues and distribution issues to be considered for this age group. Thank you.
Thank you, Dr. Maldonado. Ms. Bata? Oh, thank you, Dr. Maldonado. Ms. Bata?
Yes. I keep struggling with the terminology of booster dose, and I know that that's how it's being authorized, but I wonder, as we think about these 3 doses that people are receiving, the general public, if this isn't going to turn out to be the primary series, and that future booster, and I know we had this discussion in May or in April, but I would hate to suggest that 3rd dose isn't necessary if we're thinking of these 3 doses as part of the full protection that a person needs, regardless of the age that the person is. So that's just some things that I've been thinking about and stirring about as I heard this presentation.
Thank you. Dr. Oliver, or do you have any additional comments?
No, agree. I mean, I think, we, as was highlighted in, I think, the VE presentation, we have noted that the vaccine effectiveness against both infection and severe disease does seem to be better with 3 doses compared to 2 doses in all populations where 3 doses are recommended.
Thank you. Dr. Daly, did you wish to respond as chair of the work group, or did you want to make a comment?
No, I just have my hand up after
Okay.
Dr. Talbot and
Thank you.
Thank you. Yeah.
We'll go to Dr. Talbot.
I think this question about what to do with a 3rd dose in kids kind of highlights the difficulty of making all of these decisions throughout the pandemic with all of us wanting more information. And I think it highlights also that we are learning as quickly as we can. The work group really struggled on several levels, and I wanted to highlight some things that we really struggled with. I think without a doubt, if you have an immunocompromised child, they will need this third dose. And I think providers, who care for immunocompromised children would be very aware of this and be very ready to give that third dose. I think, however, when it comes to the rest of the population, I'm hesitant. One, with the fact that very few have gotten their first 2 doses, and I think that's incredibly important for us to focus on before we start boostering them. 2, and this brings up Ms. Lada's point, is that if it really takes 3 doses, but yet 77% of them have been exposed, could it not be that their original exposure plus 2 doses would give them that full immunity that we're looking at? 3, I think the majority of children have been exposed during Omicron, and that's really how we've been trying to give that booster to get people up over that level to be responsive to Omicron, and these children have been exposed to Omicron. So I think in my thought, that's why it was a may and not a should. It should be for those that are immunocompromised. Their physicians know how to do this. But it's really a may for those children because they need to be vaccinated for their first 2, and they've already been exposed at high levels. Lastly, I have a feeling, and please, I don't have a crystal ball, so this is not a prediction to be put in stone, but I have a feeling that we will need, for the next years to come, we will need to vaccinate people in the fall. And so I am a little hesitant now in May to say in June we need to start getting all 5 to 11-year-old boosters, and then come September, October, when they're getting their flu shot, we're going to also ask that they get another booster. So to me, it makes more sense for us to wait for the fall, unless they're immunocompromised. Over.
Thank you.
Dr. Lee, can I clarify one thing just very quickly?
Oh.
This is Dr.
Sure,
Oliver.
please go ahead.
No, sorry. Yeah. I just wanted to highlight, just because I know this is confusing for people, and so just wanted to clarify. Again, immunocompromised children have a 3-dose primary series. So the discussion of the booster in this population for kids who are moderately to severely immunocompromised is a 4th dose, not a 3rd dose. I know it's confusing, so anyway, just wanted to clarify. And I think Dr. Cohn.
Dr. Oliver, thank you. I totally messed that up, and I appreciate that. Thank you.
And Dr. Talbot,
Dr.
this is Dr. Cohn. Thank you for those comments. That is very clear reasons for the considerations around May. I do just want to make sure that members don't rely on this availability of a booster dose in the fall, in particular for this age group. Even if there are booster doses in August or September for the general population, this is a different formulation, and I don't know that we can say with confidence that there will be a fall booster dose available as early for these kids. So I just want to make sure we take that into account.
Thank you for that reminder, Dr. Cohn. We'll move on to Dr. Paling.
So first of all, thank you, Dr. Oliver, for an outstanding presentation. And I hear and very much respect what my colleague, Dr. Talbot, said. I am also leaning towards the thought process that Ms. Lynn Bhatta had shared, because all of the data we've said through, when we look through the data, is that you get a boost of immune response, and we see additional protection with a 3-dose, and there's many of our vaccines that are 3-dose series. So I'm thinking of this really as a 3-dose series. And if I recall the presentation correctly, Dr. Oliver presented that when you looked at unvaccinated versus vaccinated children 5 to 11 during the Omicron, the unvaccinated were 2 times more likely to be hospitalized than vaccinated. But when you looked at the teens and compared them to vax with boosters, it was over. It was 2.5 or a little bit more times more likely to be vaccinated if you're unvaccinated compared to a booster, further demonstrating that there is additional benefit. I also want to, as I'm thinking about this, children live in communal settings. You live in families there are people with high-risk conditions, and then they go to school, and there's fewer masks being worn in schools, and there's children with high-risk conditions. So what goes on matters to individuals, children. And so I'm leaning more towards this is convincing data to say this should be recommended. I'll listen to what my other colleagues say. Thank you.
Thank you, Dr. Paling. Dr. Daly.
Yeah, thanks so much. So I'm in favor of a should recommendation for this age group, and I'll try to give a few reasons why. I mean, I think many of our vaccines given at least in early childhood are multi-dose series. You know, we can think about Hib or pneumococcus or DTaP, where it's a 3 to 4 dose series with doses given at 2, 4, and 6 months, and then an additional dose given after a year of age, and we've learned that that provides the optimal durable protection that we desire. You know, but unfortunately, because of the urgency of the pandemic, we didn't have time to wait to see if the breadth and depth of protection using mRNA vaccines was best achieved with a multi-dose series, such as a 3 or 4 dose primary series. You know, but then we've seen presented today, I think it's on about slide 47 of Dr. Oliver's presentation, that a booster dose of an mRNA vaccine, you know, when it's given to adults during the period of Omicron, provided measurable, detectable benefit across a wide range of health outcomes. And that includes, you know, infection, emergency department visit, hospitalization, critical illness. So that data poses to me the question, why would we think that the same would not be true for children 5 to 11 years of age when they receive a lower dose from this vaccine? You know, I guess would it make sense that 5 to 11-year-olds are the only group among the age eligible for whom a third dose isn't necessary to achieve a more durable and effective immune response? And then I also put that in the broader context of the overall vaccination program and consistency across the ages. And so I fully appreciate the caution, and I fully recognize that the amount of data that we saw today is not you know, the amount of data we would ideally like to see. But for the reasons that I stated and for the reasons that Dr. Cohn highlighted, I'm not sure that a booster dose of a new strain for this age group is going to be available in the early fall. I'm in favor of a should recommendation for a booster dose for this population now. Over.
Thank you, Dr. Daly. Dr. Brooks?
Yes, and thank you. So excellent presentation, Dr. Oliver. I want to echo what Matt just said. The most compelling slide to me was slide 47, and that was that among all outcomes, those with three booster, if you will, did better than those without a booster. And why would that be any different from 5 to 11-year-olds? I think that's really important. In terms of people concerned about the fall, right now only 28.5% of children are even eligible, at least, or less eligible for a boost, because those are the only number in this age group that are fully vaccinated. Some of them have not been, 5 months out. So if this does go as they should, it probably won't be until the fall when a lot of these children even get vaccinated. I think that the May is confusing. It would be confusing. It may sow doubt in the need for any booster. So I'm concerned about a May. And ultimately, if you give a should, those that really want to get it will get it. Those that don't may end up waiting. And in terms of seroprevalence of 77%, I mean, the recommendation now is to consider waiting 3 months till you get another dose. Plus, in the studies, those that tested positive, were seropositive or tested positive, still showed a good immune response to the booster. And lastly, if we say should, more people will get boosted versus may, and then we may have more data that helps us really define where we're going. So I am in favor, for those reasons, of a should versus a may.
Thank you, Dr. Brooks. I'm going to move to Dr. Lair.
Thank you. I was going to ask Dr. Talbot to possibly clarify her position. Dr. Talbot, were you saying that you thought that immunocompromised should get the booster dose, i.e. the 4th dose, and that the general people should not? Or were you saying that right now you were holding on everyone getting the booster dose?
Thank you. No, I definitely think immunocompromised children should get a booster dose, which for them would be the 4th dose. I misspoke and said it'd be a 3rd dose for them, but for them it'd be a 4th dose. And I am very much in favor of immunocompromised children receiving a booster dose. And I think, since I'm already on, what I meant for Dr. Cohn, I know there are quote-unquote yearly vaccines coming, which may have a new variant or 2 variants. Or what I meant was that this vaccine that is currently licensed for this age group could be used in the fall. So thank you for letting me clarify.
Thank you. We'll move to Dr. Cotton.
Thank you. I would like to speak in support of significant clarity of our recommendations. In my clinical experience, deep from the clinical trenches, it is confusing when we say may. And as someone who cares for immunocompromised adult patients, I am very surprised to find that the vast majority of immunocompromised patients are not up to date with their vaccines and are vulnerable to significant, including life-threatening infection. I believe that a should recommendation would help provide the necessary clarity for this population. In addition, I'm very concerned about the BA4 and BA5 variants that are being seen in South Africa and Europe and have already arrived in the United States, for which we really need optimal vaccine protection. Prior infection does not provide good protective immunity for these strains in the South African experience. So, as a mother and an infectious disease specialist and a member of ACIP, if I had, my children are older than this age cohort, however, if they were still in this age cohort, I would give my children this booster. And I think it's important for our work today to provide the best clarity possible so people understand the recommendations we are making and we avoid nuance. Thank you.
Thank you, Dr. Cotton. Dr. Long.
Yeah, I think, I really appreciate all of what everyone has said. I just want to be sure that I haven't taken away an unclear information. I think it's wishful thinking to think that 3 doses are the deal. There's 1, there's 2, and then 6 months later there's 3. That may work if we are talking about conjugate protein saccharide vaccines, because it's an educated immunologic response that changes every time. For pertussis vaccines, it's just a dumb, repeated response. And I believe that the vaccines that we have right now with the spike protein is a dumb response in the sense that you give the vaccine, you get a boost, but what we have seen is we have only seen immunogenicity. We have not seen anything past 1.5 months post the dose. We have not seen efficacy. And we have seen that for other groups, that booster immunogenicity fades, and we only have 3 months left on it. So I don't think I have any idea, unless, you smart people here can tell me that I've missed something about the type of response that one would get with the 3rd dose that would be different than a 2nd dose. I don't hold out hope for that at all. And then the other thing is we didn't see, Dr. Oliver, your beautiful, eloquent things about the benefit of potential lives saved, potential hospitalization saved. And I know that's because there are lots and lots of moving parts. But I would say that I don't know one family in the Northeast, including my family of 3 different and small aged grandchildren, all immunized and boosted if they could be, who haven't had coronavirus in the last month or 2. So I think this is not the time to be giving boosts to 75% of children, I think the most of whom have had recent infections, because A, they don't need it right now, and B, because I don't think we know that if you get this boost when you already have high-standing antibody, that you won't be more susceptible to myopericarditis, which I would still say is myopericarditis. It's not myocarditis alone following this vaccine. So with the lack of knowing what we don't know, I would say that all children 5 to 11 should at some time have a third dose, all otherwise healthy children. And the timing of that dose depends on where they are in a current pandemic, how recently they were likely had to have been infected, and any underlying medical conditions. So I'm for a should with a lot of secondary thoughts about when that might best happen.
Thank you. Dr. Oliver, I think you did cover some of this in your slides. I want to just turn this over to you for a moment.
Thanks. Yeah, I can clarify, one thing as it looks at duration of protection and the additional benefit of that third dose. Again, I highlighted one slide and it was discussed kind of in detail back at the April ACIP meeting, but for that third dose, we see additional benefit against infection. And although that does wane, the protection against severe infection with that third dose really seems sustained, and we've got 4 to 5 months of data in adult populations that have seen that kind of sustained protection, especially in the younger adult population against severe disease. So I would say some of it depends on which outcome you're talking about, but that protection against severe disease. And then we did. I
was thinking about in this age group. We don't have that in this age group.
Okay. Yes, correct.
Hospitalizations prevented, deaths prevented by a booster versus not a booster in the current epidemic, Omicron disease in the United States. That's boosting naturally.
Correct. We presented that data for the primary series because that's what we have data that we could estimate.
Right.
Yeah.
Not booster. Yeah. Not booster in this age group. Thank you.
Thank you, Dr. Long. I see several other hands raised. Actually, Dr. Sineas, why don't you go ahead?
Thank you. As a primary care provider, it's hard for me to be having the discussion about boosters in this age group when only 28% have their primary series. However, I do favor harmonious recommendations with the other age groups as it would help with clarity as well as equity. So I think I'm in favor of a should recommendation in this case for this age group.
Thank you, Dr. Sineas. And then if my colleagues will just hold for a moment, I just want to jump in as an ACIP member and express my opinion. The more and more we look at this data, the more I'm starting to think, similar to Ms. Bata and others, that this always perhaps should have been a 3-dose vaccine. In addition, I'm just going to state that based on sort of what we're seeing about the data emerging, it also seems like it's a combination of what variant is circulating and the time since vaccination. So this really, to me, behaves more like flu. And I don't know what the future holds, but it is feeling like it is reasonable to think of this more in the framework of a flu vaccine rather than to assume that we will have permanent immunity over time. I want to respond just a little bit to some of the conversations that have been, kind of coming in and out around the role of infection and vaccination. I certainly think that we need more information about that. I think there are recommendations to hold off potentially on receiving a vaccine until 3 months post-infection in order to, optimize the immune response overall from that. But I also just, want to say out loud that we know that infection in general provides less reliable protection. We know that reinfection can occur after infection. We know that vaccination does provide highly reliable protection from infection. And on top of this, it feels like at least the small number of, or a small amount of data we saw today suggests that even amongst those who had infection prior to their booster dose, that their levels were not perhaps at the levels we would want for optimizing protection against currently circulating virus. So while I do think there needs to be more information that we can share, from prior data and from what we're seeing today, it does feel like a lot of kids who are infected are probably asymptomatic or mildly asymptomatic. I am not sure how long that duration of protection truly lasts in those kids. I also want to thank Dr. Oliver for sharing the data on PASS, because I think that we tend to focus and define severe disease by hospitalization and death, but the impact and the severity of long-haul COVID on kids is substantial. And while we might not see it in the medical care setting, it is absolutely affecting the lives of individuals who are impacted. I am also concerned that the disparities are worsening. This is not where we wanted to be in the pandemic. We wanted to see disparities being reduced, and in fact, I'm concerned that actually today, for the first time, it feels like we're going in the wrong direction. So I also endorse clarity around implementation. I don't think it's helpful to have a may recommendation for one age group and a should for another. I actually just think we should be clear about this. And also just recognize that we still have a lot of work ahead of us that we need to get done, but I do think should, in my perspective, is the right way to go. Thanks for listening. Actually, sorry, and apologies to my liaison colleagues. I'm going to go to Dr. Bell, Dr. Talbot, and then we'll go back to Ms. Stinchfield.
Thank you. Sorry. I just want to very briefly say that I think, to me, at this juncture, because we have continue to have a moving target in so many different ways, in so many different axes, that what we really need to do is be consistent and be as clear and simple as possible, given what can be supported by the available data that we have. And in that regard, and I certainly agree with everything that Dr. Lee and the other speakers have just said. In that regard, I support the should recommendation. I mean, the fact that we have such low first dose coverage in this age group, to my mind, is not a reason to hold off on recommending a third dose. And if people now will eventually have in their minds that eventually perhaps the primary series might be 3 doses, a consistent recommendation, which is simple, I think may help, to clear out a little bit of the amount of the cobwebs that we can clear out at this juncture. So I just really think that for now, to parse the details in to look for a certain kind of precision when we can't get there, and where the precision needs to land is likely going to change depending on what happens, is probably not the best strategy. So for those reasons, I also support a should recommendation.
Thank you. Dr. Talbot?
Yeah, I have a couple cautions that I just want to remind everyone. These vaccines are really good. They're really amazing, but they're not without potential side effects, 5 to 11, who has the rate.
Dr. Talbot, you're going in and out a little bit.
In and out.
Okay, sorry. Hopefully I'm getting closer now. I'm also really concerned about us trying to prevent infection. I think the goal of vaccine at this point, with a vaccine that does not match the circulating variants, is really to reduce the severity of disease and not prevent infection. If we look at other coronaviruses that circulate yearly, we get infected over and over and over again. And I anticipate that's going to be true. So how sustainable is it for us to vaccinate the population every 6 months so that there's no infection? I don't think that's going to work.
Thanks, Dr. Talbot. Dr. Paling.
I wanted to have an opportunity to clarify. I'm going to agree with Dr. Talbot that the goal is not to prevent all infections, but to prevent severe illness. And the data that was shown was quite convincing that a third dose would decrease hospitalization. It would decrease MISC. It decreases severe disease. It decreases post-COVID. All of these are serious complications that children are having, and that's why I really do believe we should be going in this direction. Thank you.
Thank you, Dr. Peeling. And now we'll go to Ms. Stinchfield.
Grace, Dr. Lee, did you call on me?
I did.
Okay.
Please go ahead.
Thank you. You jumped out a little bit there too. Patsy Stinchfield representing NAPNAP, the other pediatric organization here. I am in the should camp with many of the others who articulated the importance of that, and I am very concerned that of our already low rates, people will hear the word MAY as MEH, that meh, they just think we may be able to do that. And I think we need to add urgency based on how the data, what Dr. Peeling just listed as well regarding hospitalization and others. I was very concerned about the 40% of rural pediatricians not recommending vaccine at all. That data is very concerning when it's clear that those who are vaccinated and boosted do better almost at every measure and every age group. And so I'm concerned that the May does not portray the urgency that we have overall with vaccines. And I would also say that, for parents, if you have a child in the 12 and over, and now you have a child in the 5 to 11, and you're getting sort of mixed messages, I think it's going to be very confusing for parents and for providers. And last, I would just say, in the fall, I think throughout this pandemic, we have crossed the bridges as they came to us, and we will need to cross those bridges on boosters, et cetera, in the fall. So I would urge the committee to vote for should based on the data in front of us today, not what we anticipate for the fall. Thanks.
Thank you. Dr. Kimberlin.
David Kimberlin, AAP Red Book. I'm speaking only on my own behalf right now. I also would recommend that the committee vote for a should recommendation. I think that Americans are yearning for, crying out for some sort of simpler way of looking at this pandemic. And to add additional complexity, I think at this point would not only have an impact that would be less desirable on the 5 to 11-year-olds, but I think it could also bleed over, as has been mentioned by other speakers, to the 12 through 17-year-olds and even to the adult population. For me, the most important slide here was the workgroup interpretation grid on slide 84 of the pros and cons of should and may. The third bullet under the pros of should are likely that all ages will benefit from 3 doses of mRNA COVID-19 vaccine. To me, that's sort of the end of the discussion there, even if you take away the whole consistency of recommendations and simplicity of message. The other thing for me on that particular row over in the con is uncertainty around future of fall boosters. If you really take that to its logical conclusion, then we ought to hold off on all boosters right now as we wait for the fall for all age groups, which I know is not what anyone is advocating for. So I really think consistency for the 5 to 11-year-olds not only makes sense for them, but it makes sense programmatically. Thank you.
Thank you, Dr. Kimberlin. Dr. Hogue.
Thank you, Dr. Lee. This is Michael Hogue with the American Pharmacists Association. I also want to speak in favor of a should recommendation here, but I want to take a little bit different approach in my comments and talk primarily about the equity issue, which we haven't spent a tremendous amount of time today talking about. There were some really great slides in Dr. Oliver's slide deck about this. One of the things that I think we have to understand and recognize is that we are also in a bit of a crisis of funding for the pandemic, and particularly continued funding for vaccines and for vaccine distribution and providers. And there are deep concerns in the provider community about whether or not funding is going to be available in the future to continue our vaccination program comprehensively, regardless of patients' age. But at some point or another, COVID vaccine for pediatric patients will eventually become a VFC-provided vaccine. And the one, as was presented by Dr. Oliver, as the pandemic has unfolded, pharmacies have been very integral in ensuring that, especially in very urban and very rural communities, that patients who might not have otherwise had access to COVID vaccine have had access. And our traditional VFC providers have not been routinely providing COVID vaccine for a variety of reasons, some justifiable and others not quite understandable, but it's been the case. And the challenge we have is that for most of the states, pharmacies are not recognized as VFC eligible providers, despite the fact that CDC says that they can be. There's a total of only, I think, if my numbers right, just slightly over 100 VFC providers who are pharmacies. Most of those are in rural places in Texas and so forth. So that has got to be wrestled with as well in the financing picture as we go forward and think ahead about financing for vaccines. I do believe that should recommendations help send a message to those people who are in charge of providing the funding, i.e. Congress and others, that we think this is important, and hopefully that will give some urgency to the politicians and those who are in charge of deciding the financing pieces, that we need to make sure that the money's there to be able to do this and carry it forward. We are not out of this pandemic yet, and I think we need to send that message clearly. So thanks for taking my comments, and again, I support a should recommendation.
Thank you, Dr. Hoag. Dr. Fryhofer.
Sandra Fryhofer, American Medical Association, speaking as a practicing physician. I'm an internal medicine physician, a doctor for adults. I don't treat this age range, but I do see their parents and their grandparents, including many patients that are at very high risk of severe outcomes from COVID. Not everyone's had COVID yet, and my patients would be likely to get COVID if their grandchildren get it. We're going through pandemic fatigue in this country. Many families are planning summer vacations. Unfortunately, masks are now more off than on. Winter's coming. There are more variants. We've heard about some of them today. Which new variants around the corner? We're learning about these vaccines in real time. And as has been pointed out, many vaccines that are already accepted are 3-dose vaccines, like the hepatitis B vaccines. And based on the data reviewed so far, it seems that the COVID vaccine is likely going to be a 3-dose primary vaccine, particularly since those first 2 doses and the studies were given so close apart. I'm reassured by the safety data, particularly in this young age group at this low dose. And the bottom line is children in this age group are getting COVID. Some do fine. Some are getting real sick. Some are hospitalized. Some have died. And it's clear that these vaccines are lifesavers. They decrease hospitalization. They seem to decrease MISC and the risk of long COVID. And as what's pointed out in the very beginning of this day, there is a greater risk from this condition, this disease right now, than from other childhood diseases for which we recommend routine vaccination. I urge the committee to support a should recommendation for this 3rd dose. And I encourage all parents of children in this age group to get their children vaccinated. And we also need to ensure access to boosters to all children, especially those in historically minoritized and marginalized communities. Thank you.
Thank you, Dr. Fryhofer. Dr. Lair.
I would like to put forward a proposal, or I can't remember the word for...
Great, thank you. Actually, Dr. Oliver, there was a slide you had up. Thank you. Are you planning to make a motion, Dr. Lair?
Thank you. That's the word I was looking for. I'd like to make a motion for the committee to vote on.
Thank you. Dr. Oliver, would you please read through the proposed language?
Well, I guess could you clarify this? This is the based on the discussion, we pulled up the should. So is that potentially what your motion, the slide you would like us to pull up?
Yes, please.
Okay, I just wanted to clarify. So this says, a single Pfizer BioNTech COVID-19 vaccine booster dose is recommended for persons ages 5 through 11 years, at least 5 months after the primary series, under the FDA's emergency use authorization.
I would like to make a motion in favor of this recommendation.
Thank you, Dr. Lair, and thank you, Dr. Oliver.
It's Dr. Brooks. I second that motion.
Okay, thank you, Dr. Brooks. And thank you, Dr. Paley. I did see your hand up. We currently have a motion on the table. It's been moved and seconded that we adopt the recommendation language presented here on this slide. Are there any additional questions or issues the committee would like to discuss before we proceed with the vote? I do not see any additional hands raised, so I'll assume the committee has no objections to proceeding with a vote. I'm going to ask ACIP members to please turn on your video. And when I call on you, I'm going to ask you to state your name, whether you have a conflict of interest, and then your vote. And I'm going to warn you that I, again, will go out of order. So, and Dr. Paling is actually first up on my video, but let me just confirm everybody's on screen. Do we have everybody on? Okay, terrific. Dr. Paling, please go ahead.
This is Kathy Paling. No conflict. Vote yes.
Thank you. Dr. Long. Oh, Dr. Long, I think you're muted.
Hey, so sorry. Sarah Long, no conflict, yes.
Thank you. Dr. Lair.
Jamie Lair, no conflict, yes.
Thank you. Dr. Talbot.
Dr. Talbot, no conflict, no.
Thank you. Dr. Daly.
Matt Daly, no conflict, yes vote.
Thank you. Dr. Brooks.
Oliver Brooks, no conflict, yes.
Thank you. Oh, there we go. Dr. Alt.
Alt, no conflict, I abstain.
Thank you. Could you just comment on the reason for your abstention?
Well, I haven't been involved in about 2/3 of the meeting, so but the discussion was very robust. I didn't hear the data.
Finished, but it looks
Thank you. If everyone could please mute, we're getting some background noise. Dr. Cotton.
Neil Cotton, no conflicts, yes.
Thank you. Ms. McNally.
McNally, no conflicts, yes.
Thank you. Dr. Saneas.
Sybil Saneas, no conflicts, yes.
Thank you. Dr. Bell.
Bell, no conflicts, yes.
Thank you. Ms. Bata.
And Bata, no conflict, yes.
Okay. And this is Grace Lee, no conflicts, yes. So I believe we have all of the members who are present who are able to vote who have voted. I'm going to have to count Dr. Wharton. Let's see. I believe it's 12 yeses, no, 11 yeses, 1 no.
Dr. Lee, Melinda can state what the vote was.
Okay, perfect. Thank you.
So we had 11 yes, 1 no, 1 abstention.
Thank you. So 11 yeses, 1 no, 1 abstention. And so the motion passes as written on the slide. I want to thank everybody for your votes today and for all of the comments and participation. I want to also just give an opportunity, as we always do, to ask if our members have any additional comments that they would like to make before we close. Dr. Talbot.
Yeah, I would. I want it known that I really do want children to be vaccinated, but I think if only 30% have received 1, if not even 2 doses, we really need to spend our time and effort on educating the 70% who have not been. And so boosters are great once we've got everyone their first round, and I think that needs to be a priority in this. Thank you.
Thank you. Dr. Lair.
Yes, I am in support of this recommendation. I would, however, like to add my voice to the public comments given today and to the written public comments on the docket. I would like to ask the FDA to expedite the review of the EUA application for immunizations for children less than 5 years old. I think that's an important priority, and many parents and many of my personal patients are asking for that. Thank you.
Thank you. Dr. Cotton.
I would just like to re-emphasize the importance for immunocompromised children and adults making sure they have received all of their vaccines. As I mentioned, I'm seeing so many people, the vast majority of people, immunocompromised patients I'm seeing, are not fully protected, and I would encourage all people to take the opportunity to be as well protected as possible. I would also encourage the CDC to provide as much advertising and clarity on this topic so that people can be as well protected as possible against this horrible infection. Thank you.
Thank you. Ms. McNally.
Thank you. I feel very strongly that the recommendation should send a clear message regarding the importance of this vaccine. And for the reasons that were stated on Dr. Oliver's slide, benefits and harms, summary of available evidence, those reasons really are why I voted for should. And I the public who have questions about this vaccine and the importance of the booster, go back and review that information as it touches on the waning immunity, on the reactogenicity, on the rates of myocarditis being considerably lower in the booster, and the fact that this will offer increased protection. So thank you very much for that opportunity to talk.
Thank you. Dr. Paling. I think you're still muted, Dr. Paling.
Thank you. Like my colleague, Ms. McNally, the pros of a booster dose in this age group are strong, and the benefits we've seen from many outcomes. And that's really important and why I voted yes. I do want to highlight that only 28% of children 5 to 11 are fully vaccinated. And so this is very important that we enhance the protection of all children and make sure all who are eligible get their primary series and, when eligible, the booster. And both are equally important. Thank you.
Thank you. Are there any additional comments from ACIP members? Dr. Daly.
Yeah, thanks so much. I mean, I'm thinking about Ms. McNally's comments and just, you know, how important it is for us to communicate, you know, to parents. And I would think that in addition to what Ms. McNally said about sort of looking at the data presented today, I would encourage them to go talk to their child's healthcare provider. You know, we see data that shows that that's a person that they trust. And these are complicated decisions, and you know, we need to meet families where they're at, and we understand that they've got questions and concerns, and one way to do that is for them to take their questions and concerns to their healthcare provider, who's not going to have all the answers, but is going to give their reasoned, thoughtful opinion. They know the child, they know the family, and hopefully that can also go a long way towards hopefully improving vaccination coverage among the large proportion who haven't vaccinated their kids yet. Thank you.
Thank you, Dr. Daly. And with that, I want to just express our committee's thanks to Dr. Daly and Dr. Oliver and Dr. Talbot for leading the COVID vaccines work group, the COVID vaccine safety technical work group, and just overall allowing us to have this conversation in public meeting. I think it's been really incredibly helpful to all of us. The committee has completed its business for today. Are there any objections to adjourning today's meeting, or does Dr. Wharton have any final words for us?
Dr. Lee, thank you. Thank you to the committee for this robust discussion. We appreciate, as always, your thoughtful deliberations. Appreciate your work today, and I think with that we can bring the meeting to a close.
Thank you, Dr. Wharton. With that, today's ACIP meeting is now adjourned. Thank you again to everybody for your commitment to the ACIP and to our process. And I'm sure we'll be seeing each other again very soon. Thanks, everyone.
All right, thank you.